We'll go ahead and start. I have 11:02. Doctors Hodis and Koroshetz, why don't you kick us off?
Thank you, Luke. Well, it's a pleasure to be here offering some opening comments along with my friend and colleague, Walter Koroshetz. I'd like to begin by thanking the organizers of the meeting for all the work that they've put into it. This topic, clinically meaningful outcomes, is, of course, one that's generically critical to all the work we do in all diseases and conditions, with very special considerations now for Alzheimer's and related dementias and its clinical trials. The topic is not new. The approaches to it are not new, and I want to acknowledge as well the prior efforts in this field, both by the investigators carrying out clinical research and by those organizations who have studied and produced their own documents describing some of the parameters of importance in determining clinically meaningful outcomes. The charge before we have us now bringing together investigators, advocates, those people living with dementias, the payers and the regulators, is to plan for the future, to identify ways in which we can identify the definitions and the criteria for meaningful outcomes, make sure that these are applicable to diverse populations and audiences, determine the ways in which we will validate them into the future, all as another step, certainly not the last, but an important and critical one over these next 3 days, in making sure that our trials are designed from the beginning with input from all those who matter and providing outcomes that matter to all of us. With that, I welcome you and turn the podium to Walter for further comments. Walter.
Thank you very much, Richard. And I apologize for the background noise. I didn't make it all the way back on the metro. So I'm here halfway back to Bethesda from Capitol Hill. So what I wanted to mention in addition to what Richard said is that what's clinically meaningful is really an individual question. It depends on the person, depends on the caregiver, and that's really what we'd like to get to. Now, in terms of doing clinical trials, we are forced to look for population changes in populations related to intervention. And there we need to determine whether the differences we see are due to chance or whether they are really due to the intervention. And that's where we need these measures, which are validated, but they're imperfect. And I think we have to recognize that. And we'll hear from, I think, patients and caregivers in this session, and their input is incredibly important. But I hope that this workshop will help us to get to measures that are, as best we can put them together, clinically meaningful for the different conditions. And that being said, the different conditions in the ADRDs are different. And so in frontotemporal dementia, there's multiple different phenotypes. Each one would have its own clinically meaningful outcomes. Similarly, with Lewy body dementia, different from Alzheimer's in some instances, and vascular dementia, where the median memory is not the big problem, but executive function is more the big problem. So we have to have things that are validated across these groups, but are customized also for the condition that we're studying. And this is no light task. I think there's a lot of heavy lifting to get us to where we want to go, and I'm looking forward to the workshop and helping us get there. So thank you very much.
Well, thank you, Drs. Hodis and Koroshetz. So I'm Luke Stokel. I'm in the NIA Division of Behavioral and Social Research, and I will be welcoming everyone a second time to the meeting. So this 3-day virtual workshop will explore clinically meaningful change in the context of Alzheimer's disease and Alzheimer's disease-related dementia trials, and identify research gaps, opportunities, and tools to advance patient-centered, equitable assessment of clinically meaningful change, focusing on biomarker status, cognition, and everyday function. Importantly, the workshop will foster robust, multidisciplinary discussion between lived experienced experts, advocates, researchers, clinicians, funders, health economists, payers, and regulators. The workshop will address the criteria used to assess whether an intervention has had a clinically meaningful impact, including consideration of both benefit and harm. And I'd like to thank all the organizers, speakers, moderators, all of you, and especially our lived experience experts and research participants in our trials. So the folks on the screen in front of you, can you go back? Yeah, thanks. These are the behind the scene folks from the NIA and the NINDS Planning Committee. For session 1 on cognitive function, we have Christy Hardy and Melissa Trevino. For session 2, everyday function, we have Elena Fazio and Benford Williams. For session 3 on biomarkers, we have Amber McCartney and Christina McClendon. And for session 4, payers, regulators, and health economics, we have Priscilla Novak, Marcel Salive, and Nada Radoja. And I'm, again, very excited to be here and want to extend an extra special thanks to Nicole Kidweiler, who has been our queen of coordination, keeping all of us on mission here. So next slide. So what are the expectations for you? Well, our speakers will dazzle us with their expertise and perspectives. Moderators will guide discussion. We want all others to please use chat, either to ask burning questions or to share resources. Moderators may call on you to clarify questions or respond to speaker inquiries. But just keep questions in chat as your primary strategy for communication unless someone calls on you. We will start and stop each day on time, but we may occasionally move things around in between as unexpected issues arise. And we ask that you're please respectful of each other and each other's time. Keep questions and responses brief. And if you have not signed up for a breakout session on day 3, you can still do that, or you can join a breakout session on day 3. This is going to be an opportunity for everyone to provide your voice, to share your ideas with the group. And at the very end of the meeting on day 3, we'll have a general discussion where all your input will be elevated for a general discussion together. You'll notice throughout the meeting that each session will start and end with what we're calling a gaps and opportunities slide. These are the most important topic areas that have been identified by each group prior to today's meeting. Can you move to the next slide? Finally, I'd like to advertise NIA's 50th anniversary. There's quite a few resources that you can check out at the link provided here. Next slide. We also have a QR code and other information that you can follow to see what we're highlighting to celebrate our 50th year. And that will be it for me. Elena.
Thank you very much, Luke, and welcome again to everybody. I would like to introduce our first keynote speaker. Dr. Siobhan Riley is Professor of Applied Dementia Research at the University of Bradford in the United Kingdom. Siobhan's background is in applied health and social care research. Her research is primarily concerned with improving the evidence base for the delivery of health and social care services for people with dementia and older adults with long-term conditions such as severe mental illness. Dr. Riley?
Thank you. Thanks for that introduction. Just gonna sort my slides out here. Now, I think, has it gone back on to speaker view?
You just need to get, no, you just adjust it again, display settings, yep.
So can you see the presentation slides?
You need to go into display settings and change it to the swap. There you go. Perfect.
Lovely, thank you so much. All right, well, thank you very much for inviting me to speak. It's a real privilege and a wonderful opportunity to be able to shine a light on the importance of this topic. So why should what matters to people living with dementia matter to dementia researchers? Well, in a nutshell, if the outcomes don't reflect what matter to people with dementia, researchers are likely to be measuring the wrong things, and clinical trials are only as credible as their outcomes. So just a brief overview of what I'm going to be talking about. The slides fall into 3 parts. First, I'll talk a bit about the basics about outcome measurement, definitions, literature, and the challenges. And second, I'll highlight our work on the development of a core outcome set for what matters most to people living with dementia at home. And finally, I'll wrap up with some reflections and key questions for research and what we ought to be thinking about. So obviously, many of us are in the business of improving outcomes for individuals with dementia, but what is an outcome? So I've put a few definitions up here, which you can have a look at, but I'm pretty sure you're all going to be well versed in this, so I'm not going to spend too much time. So again, you're probably well versed in these as well. So just in case you're not, here are a few places where researchers might look to identify appropriate outcomes. So one of the first places may be to identify systematic reviews on the quality of outcome measurement instruments. You could look in the COSMIN database for systematic reviews to find out whether the review that you need is available. So when I put the word dementia into this database, there were 54 reviews which were listed. So then there's the core outcome set COMET initiative. And I'm going to tell you a little bit more about that later. Now, many of you probably know about PROMIS, Patient Reported Outcome Measurement Information System. And this displays a set of reliable and valid patient-reported outcome measurement instruments for measuring aspects of physical, mental, and social health that can be applied to adults and children. But it'd be great to have one of these focused on people with dementia. For clinical practices purposes, the standard set developed by ICHOM, they recommend that the outcomes that they've got that matter most to people with dementia are measured around the world with the ultimate goal of improving the value of care. So there've been quite a few reviews that have looked at outcome measures. And this one here focuses on the Cochrane Dementia Cognitive Improvement Group's register of studies. And this review looked at 676 dementia trials, 129 mild cognitive impairment trials. And they found that 70% of the trials reported cognitive outcomes, 29% looked at functional performance, only 13% measured quality of life. So the Roadmap Consortium carried out a systematic review of what outcomes are important to patients with mild cognitive impairment or Alzheimer's disease, the carers and professionals, and they identified 32 outcomes, clinical, practical and personal outcomes across 7 domains in the 34 included studies. So the Venn diagram shows the overlap in what the stakeholder groups considered important. Those in the red were more frequently highlighted, and those in the green less so, and those in the black were represented only in 1 to 3 studies. So De Benedetti et al., they conducted a qualitative interview-based study assessing what matters most to patients with or at risk of Alzheimer's disease and their care partners, with 60 individuals and care partners across the 5 Alzheimer's disease stages. So I think what's interesting here is the emphasis on symptoms and deficits in memory, communication, concentration, planning, orientation. And maybe this can be explained by the fact that the content of the interview guide was driven by the concepts and the domains included in the Alzheimer's disease assessment scale, ADAS-COG, and the information from the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders. So we, before the research I'm going to present shortly, before we conducted this, we reviewed 6 previous consensus exercises that sought to attain consensus on outcome measures in dementia care and research. And we obviously found a great deal of variation in the outcomes recommended. It was also important to note that most of the prior consensus exercises placed more emphasis and weight upon the participation of professionals relative to the people living with dementia. So it was really unclear if outcomes being recommended were important to people living with dementia, because people living with dementia were rarely consulted, and the choice of outcomes may be more driven by the expectations of the research community. Of course, measuring outcomes is challenging due to the heterogeneity of the profile in the conditions and people living in a variety of settings. It's unclear if outcomes are really important to people living with dementia. And there's a high degree of variability in the tools, lack of harmony across the trials, and this is all presenting problems when you're comparing effectiveness across studies. There's also a proliferation of measures, but how do we really get trialists and researchers to decide on the same measures or what the measures should be? And there's real impetus on obtaining research funding to measure and evaluate interventions, which can, I think, perpetuate the difficulties with existing measures, because there isn't that long to choose the measures, and people look at reviews and they'll choose measures based on those. So one approach that has a lot of potential to address these challenges in outcome measurement was the development of a core outcome set. So the idea of a core outcome set is pretty simple. You undertake research to attain consensus and from the key stakeholders on what's most important or core, and then you review the existing measures against these core outcomes. And the output is a recommendation of what outcomes should be measured, how to measure them across all trials within the scope of a core outcome set. This enhances comparability, responsiveness, and relevance of research, and it also reduces waste. So this is just a screenshot of all the dementia-related core outcome sets that's listed in the COMET initiative database. So you can see there aren't that many. But the one that's highlighted is the study that I'm going to tell you about. Before I tell you about this, special thanks to our funders, our co-researchers and the whole study team and the advisory group. So we had our underpinning value of co-research philosophy, and we embedded the participation of people living with dementia and their care partners as co-researchers throughout the study to design creative and inclusive methods and processes. We had 2 main research questions in relation to non-pharmacological community-based interventions for people living with dementia at home. So which outcomes should be measured from the perspective of people living with dementia, their care partners, health and social care professionals and policymakers and service commissioners and research leaders, and how should these outcomes be measured? So we used a 3-phase mixed method study design, conducted 35 interviews, 4 focus groups with 55 people living, or 55 people. Yes, they were all living, and a literature review in phase 1. So we identified 170 outcomes, possible outcomes, and then whittle these down to a manageable number and rework the outcomes into a suitable format so people could actually answer questions on them in phase 2, which consisted of a Delphi survey and consensus meeting. So the majority of our data was, well, for phase 1 and phase 2 was collected in England, and 54 outcomes made up the Delphi survey. So people had to rate the importance of the 54 items. This was sent to over 300 people in the stakeholder groups mentioned earlier, and then it was sent again a month or 2 later to repeat the survey. So we enlisted the support of the late Tony Husband, who was the renowned cartoonist and illustrator. We really wanted to make the findings accessible to as many people as possible. And so he documented the discussions at the consensus meeting. So we grouped the 54 outcome items into 4 domains. So self-managing dementia symptoms, independence, friendly neighbourhood and home, and quality of life. So it's interesting that those items that were prioritised in the 2 rounds of the Delphi survey and the consensus meeting, highlighted in yellow, show that only 3 of the 13 items were symptom related. So after rating the importance of each outcome in round 1, the second round of the Delphi survey, participants were able to change how they rated the outcomes. So after being given access to how other participants in other participant groups had rated the outcomes, there were actually a lot of changes recorded. So 76% came from professional groups, and 65% of these changed how they rated the outcomes to align themselves to the views of people living with dementia. So given the exclusion of or lack of meaningful participation of people living with dementia in previous consensus exercises, we would suggest that not only did we develop a meaningful method of creative data collection and capture, but an approach that gave equal weighting to the views of people living with dementia and privileged their experience. So here are the final set of 13 core outcome items highlighting what matters most to people living with dementia. I'll just give you a second or 2 to look at those. So some of the outcome items we didn't find represented in the trials we looked at. So for example, feeling safe and secure, feeling valued and respected by others, and having a laugh. And continuing good relationships with people who are important to you. We didn't find this represented in the trials we looked at either. So many of the 13 core outcome items have substantive overlap with the emergent concept of social health, which many of you know is a shift in focus from symptoms, deficit and disability towards capacity and the potential of the person with dementia. So Shared is a project designed to uncover the links between social and brain factors connected to cognitive decline. And it's the first international effort to harmonise work on social variables and examine their link to the onset and course of cognitive decline. So social health is a driver for stimulating the use of cognitive reserve through the active facilitation and utilisation of the individual's capacities and those of the social environment that slows cognitive impairment or maintains cognitive function in old age. So cognitive reserve is the brain's ability to use brain networks more efficiently or to recruit alternative networks in the presence of pathology. So having a strong social health is associated with reduced risk of cognitive decline and dementia, and poor social health is a risk factor. combinations of social health characteristics have a cumulative effect on cognitive functioning. So I'm just flagging up the conceptual framework that's been published recently in Frontiers in Psychiatry for the recognition of social health in the context of dementia research, which are in line with quite a few of the 13 core outcome items. So in phase 3 of our study, we conducted an extensive systematic literature review to identify outcome measurement instruments that have previously been used in dementia care research to determine how or even if the 13 outcome items can be measured. So we looked at English language questionnaires that people living with dementia complete themselves, ask subjective questions, and are used in the social health or social research in the community. So not drug trials or those used or designed for clinical or institutional care settings. So 76 measures met our inclusion criteria. And how should these outcome measures be measured? So for each of the 76 outcome measurement instruments that we identified in the systematic review, we looked closely at each of their items in each item to see how it reflected each of the 13 core outcome items. So this is one example. This shows the engagement and independence dementia questionnaire, and it was the highest scoring questionnaire. So we simply compared each of the outcome measurement instrument items in the columns with the 13 core outcomes in the rows, trying to identify where there was a good match. And we did this for each item on a 4-point scale. So if there's a green, it meant that it was thought to be very good, orange, adequate, yellow, doubtful, and red, inadequate. So there's a hell of a lot of red on most of the instruments. So had 85% of the items in the outcome measurement instrument be rated as adequate for any of the measures, or adequate or more, or good, very good, then we would have further assessed content validity and internal consistency and responsiveness. So we found an incredible level of dissonance between the 13 core outcome items and the contents of the 76 outcome measurement instruments. So this table shows the top 10 outcome measurement instruments that covered most of the items in our 13 core outcome set. So as you saw in the previous slide, the most relevant instrument was the engagement and independence dementia questionnaire. And this was adequate or very good for only 7 of the 13 outcome items. So many of the most frequently used and unknown measures fared pretty poorly. And I've added a few of these to the slide. So I've added, I've highlighted the popular DEMQual. It's the only self-report quality of life measure that's highlighted in the 2019 UK National Institute for Health and Care Excellent Guidelines. But this measure was rated adequate or very good for only 2 of the 13 core outcome items. So our research highlights that existing outcome measurement instruments do not really reflect what key stakeholders value. I should note that core outcome set studies do require updating periodically, and of course further testing and refining from people from diverse and different social and cultural groups. So could our findings help to explain the lack of or minimal positive findings in recent trials? So there've been a number of trials of psychosocial interventions for people living with dementia where there were indications of improved psychological well-being in those who received the intervention, but that either their primary or secondary outcome measures just didn't show any difference. So here's one example, journeying through the dementia. And another one, the Great Trial. This showed that the qualitative findings were at odds with the results from the secondary outcome measures. So the intervention may have provided wider benefits that were just not detected by standardized measures. Similarly, in REM care, trial of reminiscence groups, there was a lack of positive findings, and this stands in contrast to the reported enjoyment and benefits reported by participants and facilitators. So the authors also, for this trial, also recommended that interventions for people with dementia should be evaluated in relation to their immediate within session effects, rather than focusing on longer term changes. So if we were to go back to the basics in terms of the evaluation literature, none of what I'm saying is rocket science. Focus on outcomes is fundamental for measuring impact. So if we're measuring irrelevant or unreliable measures, this can completely undermine the worth of an impact assessment by producing misleading estimates. So this is really just a summary of what I've already said. So existing outcome measures do not sufficiently measure what matters most to people living with dementia or the concept of social health. They tend to focus on symptom reduction or broad conceptualizations of quality of life. This might explain the lack of positive findings in trials. So are researchers measuring the wrong things? So can researchers measure clinically meaningful change if the outcome measures don't reflect what matters most to people living with dementia? So will these findings help convince dementia researchers why what matters most to people living with dementia should matter to them? So really, this is the most important slide, one of the most important slides. I want this to be a call to action, and it obviously aligns with the whole topic of the workshops. And can we not assume that we've got measures available that will work? Can we not settle for measures that don't work? Can we somehow work towards systemizing the process, that we can work together and avoid duplication of effort, and work as an international network so we can facilitate better research? Can we collaborate worldwide to make rapid progress on person-centered measurement and evaluation? Can we develop and test new measures rapidly through an international collaborative of researchers to ensure diverse people living with dementia across the progression of disease and their care partners have their voices heard and are central to the research process, so that we have meaningful outcomes consistent with what matters most to diverse people living with dementia and their care partners? This is, you know, the icing on the cake. When we've done all this, can we then have a searchable database of all outcome measures? And can we use technology to support real-time, in-the-moment measurement? So one of the vehicles for achieving this and addressing the challenges in outcome measurement might be to develop a global organisation committed to improving outcomes for people living with dementia, modelling it on really successful organisations in other disease areas like OMERACT. So, where they're focusing on outcome measures in rheumatology, and they've been going for I think since the early 90s. So I hope this presentation and workshop will inspire you to really think about how we're going to use outcome measures that really measure what matter most to people living with dementia. So being able to measure the core outcome set items that I highlighted in the future would really herald a paradigm shift for dementia research, be responsive to what key stakeholders value, and enhance the potential for trials to show a clinically meaningful effect, leading to interventions that are much more likely to get funded, because then we have a robust evidence base. So these are just the references that I've used. So thanks very much for listening, and I'm really looking forward to seeing how we can progress this over the next few days and years. Thank you.
Thank you so much, Dr. Riley. We really appreciate your thoughts on this most important topic. We do have a few minutes available for any questions from anybody on the call. I would encourage you to put your questions in the chat, or if you have a question that's a bit more complicated, I'm also happy to ask our contractor to unmute you to ask your question out loud. Do we have any specific questions for Dr. Riley, or any comments that anybody would like to share, either in chat and I can read them out loud, or if you'd like to go ahead and ask a question, we can unmute you. And Luke, I see you have a comment to make as well.
Yep, I was just going to read one of the questions from Matthew in chat. Can you address the potential impact of having the NHS with its warts in the UK as opposed to the massively varied healthcare systems in the US?
It just cut out a little bit there, Luke. Could you repeat that? Sorry.
No problem. Can you address the potential impact of having the NHS with its warts in the UK as opposed to the massively varied healthcare systems in the US?
Wow, that's a big question. Yeah, I'm not sure where to start there. I don't think I can. Yeah, I think we're having lots of issues here, as he says, with warts, and it's very difficult. I think measuring outcomes, I think, is not only important for the actual research that we do, but it also will help, if you're measuring the right outcomes, help to drive the quality of the services that people are actually going to be receiving.
And maybe the broader question there is kind of pointing to your call to action for international collaboration, what you see as the opportunities and challenges there for building international coalitions for this work.
Yeah, I mean, I think people are willing. I think one of the constraints is funding, but I think that's where, if people are working together and there is opportunities for including outcome development work within larger scale research studies. It doesn't necessarily have to be focused just on the developing the outcomes. It can be part of bigger studies, and I think there are lots of missed opportunities for doing that because we're not working in a big group.
So why don't we have Ian Kremer ask his question? Ian?
Hi, thanks. Terrific presentation, fascinating research. I'm wondering about the composition of the individuals living with cognitive impairment that were part of identifying and narrowing down to those 13 items. And if you could describe anything about either their diversity or lack thereof, particularly around racial, ethnic, cultural, and around socioeconomic status.
Absolutely. So there was some diversity in socioeconomic status. There was much less diversity from diverse backgrounds, from different groups, different ethnic groups. There was some, but again, this is well, lots of researchers are struggling with this in England. One of the things that we have is a join dementia research, so people can sign up to be parts of studies, but actually, and that's it's a brilliant vehicle for recruiting to studies in the UK. But I heard a statistic recently saying that I think 87 or 85% of the people who were signing up to that were white. So it really doesn't represent the whole population. So I do think we do have to do a lot more work. And as I said in the presentation, or I alluded to, just because we do, well, this was one core outcome set study. So we would never settle for just one trial. We have to do more work around this area. So we have to repeat this sort of work with different populations.
Thank you. And I shared another Tony Husband cartoon for those that are fans.
Oh, lovely.
So we're going to take one more question for Dr. Riley from Jeffrey Cummings, and then we'll move on to the next session. Jeffrey?
Yeah, really great talk. Thank you so much. So I'm a trialist for pharmacologic trials. And of course, we would like to move our outcomes more towards what patients most want. So you presented mostly on effectiveness research. Would you fold these same set of thoughts into efficacy outcomes and double-blind placebo-controlled trials? Or how do you think about the application of your research in the double-blind placebo-controlled setting?
Oh, that's an interesting question. I mean, maybe for my sort of, maybe I'm quite ignorant on this, Jeffrey. But I would say, why wouldn't it cover that as well? I don't know if you can think of reasons why it wouldn't be.
Well, I'm just thinking, for example, there was an emphasis to say we should measure right during the activity because that's when the patient is enjoying it. I thought that was interesting. Whereas in trials, we're mostly thinking about 18-month outcomes. We're thinking about the long term. So how do we reconcile these different ideas?
Yeah, absolutely. And I think what was alluded to in my presentation as well is that we probably do need to be thinking about in the moment measures as well. And I think much more development needs to be done on that, especially for people with advanced dementia. That's a no-brainer. We need to be measuring in the moment rather than any other. And it may be that this is again something that we can all collaborate on. Not sure how we do that, but maybe over the next few days we'll work that out.
Great, thank you so much.
Thank you.
Thank you, everybody, for your questions. And again, thank you, Dr. Riley. We're going to ask that you feel free to answer questions in the chat as your time permits, and we'll now move to the next session. Dr. Trevino?
Thank you. So now we'll start the cognitive function section. I am Melissa Trevino. I am from the National Institute on Aging, and I will be one of the co-chairs along with Dr. Christy Hardy. So I will be introducing two of our session speakers, Dr. Maria Margrin from the Duke University School of Medicine, and Dr. Robert Gibbons from the University of Chicago. And now let me turn it over to Dr. Hardy.
I'm Christy Hardy. I'm a program director at NINDS and a practicing neuropsychologist. And I will be introducing Dr. Laura Germain and Dr. Rosie Curiel-Sid as our moderator today.
Good morning to everyone. Thank you so much for joining us. So as it relates, I think there's a GNO slide that we'll put up next as we start our session in cognition. And as it relates to both short-term and long-term longitudinal measurement of cognition specifically, this group would like to present some real gaps that we're contending with in the field, as well as opportunities that might have the potential to bridge those gaps to improve the clinical meaningness of our cognitive outcome measures. And so the first would be equity in cognitive measurement. So it was identified that there is a need for skillful and informed adaptation and cross-cultural validation of cognitive tests that measure clinically salient outcomes. And it was also identified as a gap that there is a lack of harmonized longitudinal assessments of diverse Americans, which really presents a delay in having some of these gaps filled. But some opportunities might be developing novel cognitive testing approaches, some of which you'll hear about today, and technologies as well that are sensitive and specific enough to detect and or track, of course, both clinically meaningful change that could be indicative of disease progression. And another opportunity, agreeing with Dr. Riley, is to facilitate collaborative research among investigators to really better understand the similarities as well as the differences of how AD and ADRD present and progress in older adults, and accelerate the availability of valid and reliable cognitive measurement. And Dr. Maria Marquin will speak to us more about this session, this gap and opportunity. The second major gap that we'll be reflecting upon today has to do with adaptive measurement of cognitive abilities. So it was identified that there is a need to improve upon the precision of repeated cognitive measurements by reducing practice effects that are very often produced by traditional cognitive assessments, and reduce time and burden. Some opportunities that might bridge this gap that you'll hear about today have to do with large cognitive item banks that can be very adaptively administered and even tailored to a person's cognitive ability with precision, and can be repeatedly administered with reduced practice effects. And this is important because it has the potential to enable high frequency longitudinal assessments across a person's lifetime. The third gap that we will be beginning to address together is how to measure cognitive change dynamics using cognitive tools, digital cognitive tools. And so there's a lot of innovation here that you'll be hearing about today. So there is a need for novel and clinically meaningful outcome measures that can combine cognitive function with health or physiological factors of the disease. And this includes the development of novel paradigms and tools that are more naturalistic or ecologically relevant as they relate to both stimuli as well as to data acquisition methods. And the opportunity might be that we can discuss and that you'll hear about is the actual availability now of scalable digital measurement tools that can allow us to move beyond single time point assessments. So we will see this slide again towards the end of the session, but we can move on now to presenting our first speaker. So we'll kick off the workshop on cognition, the specific section, with Dr. Maria Marquina, who is an associate professor of medicine and psychiatry and behavioral sciences at Duke University School of Medicine. So she's going to share important insights about equity as it relates to cognitive measurement. So Dr. Marquina, we're delighted to welcome you today.
Thank you very much, Dr. Coriel Seed, and it's my privilege and honor to be here joining this session. I really hope that together we can move the field forward over the next couple of days. And I hope to add a bit to this discussion. So our group decided to start our session focused on equity in cognitive measurement because we consider it central to moving the field forward in this arena. I'm a clinical scientist and I'm a neuropsychologist, and I'll be sharing some work that hopefully will be of help. So next slide, please. So similar to Dr. Riley, I'd like to start with some basics. So, you know, we talk about cognition and all, but a lot, but what do we mean when we say cognition? So cognition really stems from cognition, which is examination, learning, or knowledge. And there's a number of definitions that have been put forward to define what cognition is, some of which are there in this slide. Important to consider in the different definitions, or something that come across that I'd like to highlight, is that it involves a number of heterogeneous functions. You know, some of the ones that we're more used to thinking about in this field of ADRD are learning and memory, and maybe language, both the understanding and production, problem solving. There are other aspects of cognition that are also important to think about, which might be cognitive aspects of emotion. So how do feelings and thinking interact? social cognition or the role of cognitive processes that might play in social interactions, as well as metacognition or the process of thinking about one's own thinking and learning. So I think that the bottom line here is that cognition really encompasses a number of different functions, many of which we consider important for who we are as human beings, maybe not the most important, but important for who we are. Next slide, please. Another aspect that it's important to consider is that we don't directly observe cognitive abilities, but we actually infer them from behavior. That's how we're capturing cognition in our measurements. So we might do this via self, so the report of the person of their own cognition or a knowledgeable informant. Some of the gold standard ways in which we measure it are via paper and pencil or computerized cognitive tests. So performance-based cognitive tests, like maybe a list learning task and other measures of that kind. And really what we're measuring there is the behavior in response to the structured stimuli that's put in front of an examinee. And that's how we're capturing cognition. There's also more novel measures that were alluded briefly before, and that I'll touch upon very briefly today as well, which is capturing these markers of cognition via the behavioral signatures that can be captured via technology. So what we might call digital signatures of cognition. So as we think about cognition and how we capture it, it's extremely important to consider that since it is inferred via behavior, we need to be mindful that behavior is multiply determined. And so there are many factors that fit into what shows up in our measurement of cognition. So next slide, please. So what you see represented there in that figure. So when we think about cognitive test performance, what are we capturing when we look at cognitive test performance? So there's decades of research in our validated test showing that what comes up in performance on a test is a result of neurological function. And, in the case where we're trying to identify dysfunction, can identify people with and without neurological disease or injury. It's also important to consider that when we measure, when we look at performance on a cognitive test, this is also capturing lots of other aspects of the behavior of taking a test, which are cultural, life experiences, language, emotional state, environment, and many others, some of which we're still trying to understand of what's captured. Importantly as well for us to consider is that most traditional tests that we use, both self-report and performance-based cognitive tests, have been developed by and for primarily non-Hispanic white English-speaking people, particularly here in the United States, but also abroad. And so the constructs that we think of when we think about cognition are really rooted within that cultural language group. It's also important to keep in mind that because we know that cognitive test performance is an imperfect index of brain function, so it reflects brain functioning and dysfunction, but it also captures a number of other important elements, is that we have methods that we've developed to try to disentangle those elements and be able to get at the aspect of the performance that is indicative of brain dysfunction when we're trying to use this test to identify something like Alzheimer's disease or related dementia. These tools that we use to interpret findings are also based primarily in, largely non-Hispanic white English-speaking samples. And this has resulted in important biases in our tests and in the interpretation of test performance, particularly when we're looking at performance at a cross-sectional level and beyond as well. So next slide. So one example to highlight is one that I've been involved in is, the neuropsychological battery that we use as part of the uniform data set. So as many in the audience might be aware, the uniform data set is this collection of measures that are used across NIH-funded Alzheimer's disease research center across the country. And within those collection of measures, we have a neuropsychological battery, which we use. And so in this there's been various iterations. The one that's currently being used is the UDSV3, and getting ready we're working on the UDSV4. As you know, importantly, this version of the UDS, the V3 was introduced in 2015. A few years, the 2018 normative data or reference data to use to interpret performance on this test and be able to identify whether performance on this test is indicative of brain dysfunction were published in 2018, largely based on non-Hispanic white English-speaking cohort. In 2020, they were expanded to include a larger number of Black African-American people in the US, yet they were about 16% of the population. So roughly about 1,300 African-American or Black people were included in the sample. And recently, just last year, we published normative data for Hispanics or Latinos, which was based on a much smaller sample. And I think a couple of things to think about as we're looking at this, and of course, it's just one example, but one that I think is important to highlight, given that an important part of the research in this area is put forward by the ADRCs, is the time that it has taken to put forward these reference standards to accurately identify neurocognitive dysfunction in diverse or minoritized ethnic racial groups, and the composition of the samples and the limited representation of ethnic racial minorities. And these are just some of the ethnic racial minorities in the US, right? There's others that are capturing, others that we actually are not capturing yet that we need to consider. So next slide, please. So after developing this normative data, and this is meant primarily as a representation of why these are important, what our team did is also utilizing data available via the National Alzheimer's Coordinating Center, which coordinates data from all the ADRCs. We looked at data from self-identified people of Hispanic, Latinx descent that had different ratings on the clinical dementia rating scale, or CDR, as you see in the different columns there. So we use data from CDRs of 0, 0.5, which is questionable impairment, or 1, mild impairment. When we used the reference data that we developed for Latinos, English and Spanish speakers, we see in the graph represented there how there's a staircase sort of effect, which is expected. So people that by clinical ratings are determined to be normal or not cognitively impaired, there's a much smaller proportion of the sample that has global neurocognitive impairment as identified by the cognitive battery. And as we move in the rating of possible impairment, there's, based on a clinician's rating, we see more cognitive impairment based on this collection, on this battery of neuropsychological tests, when we're using reference data that were developed, again, for Latinos. Everybody here represented is self-identified Latino or Hispanic and living in the US. So what we did next, and what you see in that little 2x2 table there showing sensitivity and specificity. So sensitivity, as many in the audience might know, it basically makes reference to how well a test identifies the disease when in fact a disease state exists. And specificity refers to how well a test might identify the absence of a disease or a condition, in this case neurocognitive impairment, when in fact that's not present. So when what you see, the sensitivity and specificity shown there, is using the same raw data, meaning the same raw scores on cognitive tests. The difference is whether you're applying the reference standards that were developed for this population, for the Latino population in the US, or you're utilizing the reference data that were developed for largely a sample that's largely non-Latino white English speaking. So with our normative standards, we see very decent sensitivity and specificity of the neurocognitive battery to identify whether there's an impairment or not based on clinical rating. When we use norms that had been used in the past, and again, developed for other groups, we see very good sensitivity as well. So the test can identify who's impaired, but we see a specificity that it's roughly a chance level, meaning it's almost like flipping a coin when we're using these reference standards as to whether this test are able to identify who does not have an impairment. So I wanted to show this data primarily to underscore the importance of considering the cultural and language background of people when we are interpreting results from neurocognitive testing. I think it's very important. Of course, this is mainly used for cross-sectionally, right? Which might be important or very important to consider when we are identifying within minoritized groups who fits our criteria for clinical trials as impaired or unimpaired. So it's very relevant in that way. It's it's less relevant when we think about looking at change over time. And I'll talk about that in a little bit. Next slide. So as much as I think it's extremely important to consider again that many of the tests that we use were not developed for, were mainly developed for non-Latino white populations, English speaking in the US, there's been, tremendous efforts at promoting equity in cognitive measurement throughout the years. So we do have guidelines for cognitive test adaptation in different cultures and languages. There's a number of successful examples of adapting tests and harmonizing batteries to assure construct equivalence, basically making sure that we're measuring the same thing across cultures and language, that we accurately interpret the results of tests across cultures and languages. Some of the examples are there as references. There are many others as well. Typically, there's two important aspects of these efforts, which consider both careful consideration of the cultural language factors, as well as applying relevant statistical approaches and test formats, both computer adapted and fixed formats, and as well as different approaches like differential item functioning and test of construct invariance to make sure that we're measuring the same thing. There are also some examples of developing of the tools from the get-go, considering multiple cultures and languages that have been put forward and have been quite successful, at least for some cultures, right, that are also set out there, both based on classical test theory and item response theory. There's also an increased understanding by important organizations, and in our case, being a neuropsychologist from the American Psychological Association, that are recognizing the importance of moving this field forward and supporting efforts like the presidential task force that was put forward by Dr. Frank Worrell, president of the APA a couple of years ago, which I've had the honor of chair with a number of leaders in the field, which are really trying to solidify efforts to move this field forward. So there's a lot of excitement, a lot of work that has happened over the years and that continues to happen to promote equity, but there's definitely lots that needs to be done yet, lots. So next slide, please. So moving forward to cognitive change and assessing cognitive change over time. So as neuropsychologists, we typically ask ourselves at least these two questions when we're looking at changes in cognitive test scores. One is when we're looking at change over time, we ask, to what extent do changes in test scores over time, so repeated testing reflects changes indicative of a brain dysfunction, of a brain disorder, or are indicative of error, right? Of just, these changes would have happened regardless, right? Anything, this would happen whether there's a brain disorder or not. So we're trying to identify whether that indicates that there's a brain disorder happening, brain dysfunction. The other part that I think has been, it's tremendously important, a lot of what I'm hoping, and I'm already very excited to see from the get-go that we're focused on this, is to what degree these changes are clinically meaningful to the people that are living with the disease and their family members and others around them. So next slide, please. So to answer the first questions of to what extent do changes in test scores reflect changes indicative of brain dysfunction? Again, I put some reference there just in the interest of time. There are varied statistical and psychometric methods that have been put forward. They differ with respect to their mathematical models and assumptions regarding the nature of the test data. Some of them will be discussed in our session. Some maybe of the more commonly used in neurocognitive testing traditionally have been reliable change index, standardized regression-based change scores, and so forth. So we do have ways to try to identify, is this indicative of a underlying brain dysfunction or not? Importantly, though, there's limited research on how repeated testing might or occurs across persons from diverse backgrounds. And there's a lot that we need to do in that space. And some evidence that the effects might differ based on a number of factors. So next slide. When it comes to the second question of assessing meaningful cognitive change, I think there's a few things that have been discussed already by Dr. Riley and that are tremendously important. I also found the concept put forward by Dr. Borland, minimal clinically important difference, as a important one to consider, which is stated out there. I think it's important as we move forward in this field to consider that what's meaningful or beneficial, it will differ among individuals and over time. So what might be important to me, to my family member today, might not be the same that's important a few months right down the road. What might be important to me might not be as important to you and to other people, and the extent to which the individual, significant others, and their cultural environment values cognitive ability. So different cultures across time. So here in the US, we're very centered in our cognition, I found, but other cultures maybe value other aspects of who we are as human beings that are not represented in cognitive abilities. And it's tremendously important to consider those. I think it's also good to think about what's impacted and also what is preserved, both cognitively and in other ways, and the extent to which this cognitive change, of course, impacts daily life. And I'm sure we'll have wonderful discussion about this in the next session after us, focusing on impacts in daily functioning. So next slide, please. So last piece of information I'm going to put out there, mindful of the time, is some of these more novel approaches to capturing cognitive changes over time via technology. So this is just to highlight, the work that one of the works that I'm involved in, but there are many other people doing work in this space and doing wonderful work. This I'm doing in collaboration with Dr. Rayanne Moore at the University of California, San Diego. We conceived this study when I was there, and we're looking at different via markers of digital signatures of behavior that are captured via mobile devices in a passive way that do not require people to particularly make some sort of response, but just capture as they go along in their daily lives, whether we can use these markers of behavior change to identify who might have a cognitive disorder. So this is preliminary data from this study in just 50 people, very, very preliminary, just to highlight the potential of this type of work. Represented in the graphs there, we see findings from the keyboard data. So basically the patterns of how people type in their smartphones. So not what they type, but how they do it. And so in the first graph that you see up there in the right top corner is the median typing speed across a 4-week period. of people just using an app in their smartphone that captures this typing speed. So we see that those metrics differentiate people that have risk for ADRD as based on having cardiovascular disease or CVD, as you see noted there, versus a group that does not have any, does not have either mild cognitive impairment or cardiovascular disease as a marker of risk for ADRD. And then we see that another pattern of marker of the keyboard of how much you're moving the cell phone as you're typing differentiates between people that have MCI and do not. And one thing that I purposely left out from the get-go, although you might have gathered from the title of our project, is that all this data are in Hispanic Latinx people only, age 50 and over. So it's very important. We have an opportunity here, a wonderful opportunity with these novel methods to make sure that we get it right this time, that we include a diverse group of people from the get-go as we're developing these algorithms and trying to capture what works and what doesn't work. In my mind, this doesn't mean, old with the old and new with the new. I think there's a lot to learn from all sorts of different approaches, and also basic principles of cognitive measurement that I shared earlier are tremendously important to keep in mind in the development of these measures. But we do need to include a diverse group of people from the get-go here. Next slide. And to wrap up, I'm not great at keeping track of time, but just to conclude, so remember, cognitive abilities are varied and are inferred from behavior, which is multiply determined. The development of traditional cognitive tests largely by and for English-speaking non-Hispanic whites. However, we have established guidelines, approaches, and successful examples of adapting and developing tests that can enhance equity in cognitive measurement. Next slide. These novel approaches for capturing behavior changes via technology hold great promise for both identifying and tracking of neurocognitive disorders over time, and it is crucial that these novel approaches include and consider diverse populations, both in their design and the implementation. And there are crucial challenges to equity in defining and measuring clinically meaningful cognitive change. Some of the most important ones, in the interest of time, I'll just mention two. One is this concept of health equity tourism. So when privileged and unengaged scholars enter this health equity field without appropriate training, we see a similar pattern with the measure of cognition and cross-cultural cognitive measurement. I think it's tremendously important that we value expertise that it's needed, both in health equity and cross-cultural cognitive assessment, to make sure that we have the best assessments and the most equity assessments moving forward. Next slide. So moving forward, this is my last words on this slide. One is that I think as we move forward, it's tremendously important that we continue to keep in mind this health disparities research framework that was put forward by NIA a number of years ago now, that really is rooted in this concept of health and disease as a biopsychosocial model or entity, which it's crucial that we're considering all these aspects of human health and disease as we think about what's clinically meaningful. If you can click one more time. I also think it's tremendously important that we think about, drawing a figure from Marie Bernard's work that had underscored the lack of diversification in the research workforce, particularly in the US. That we are mindful of different perspectives, that we consider different perspectives, not only in our personal backgrounds, but also in our training. So me as a neuropsychologist, I might be an expert in one aspect of the elephant, but I'm never going to be able to see all aspects. And it's only when we're working together that we can get a more holistic view of what might be important. And last click, please. As was, beautifully shared by Dr. Riley, meaningful to whom. So I think the experience of the people living with the disease and their family members need to be central to how we're thinking about clinically meaningful outcomes. Next slide. And I'd like to end by acknowledging the wonderful group of collaborators that I've worked for, the work that was highlighted here, and the funding agencies and groups. And with that, I'll leave the stage to the next presenter. Thank you very much.
Thank you so much, Maria, for giving us so much information. There are some questions that came up in the chat, some questions I have myself, but we'll reserve them towards the end in the interest of time so that we could move on to the next chat. But we're excited to have you working on that UDS4 and all of the initiatives that you've spoken of, to see, it's an opportunity to do better now, particularly as we acquire social and structural determinant of health data, as you mentioned. That's such an important aspect. So I'm really glad you're at the forefront of that. Our next speaker today is Dr. Robert Gibbons. He's a professor of statistics at the University of Chicago, and Dr. Gibbons is going to be sharing his work exploring adaptive measurement of cognitive ability. So Dr. Gibbons, please take it away. And you may want to unmute yourself, please.
Let's try that again. Thank you, Rosie, and thank you, Melissa, and your colleagues at the NIA for the continued generous support of our work. Yes, I am a statistician, and statisticians are in fact people who wanted to become accountants, but we didn't have the personality. So I will do my best. So let me, next slide, please. So the classical definition of what is measurement is the process of obtaining the magnitude of a quantity relative to an agreed upon standard. That's a terrible definition because it assumes we have an agreed upon standard. And in many areas of the social and behavioral sciences, we don't. Not everything that can be counted counts, and not everything that counts can be counted. Albert Einstein said that, and it's important to start every presentation with a quote from Albert Einstein. And if you start with Al, you should end up with a quote from Florence Nightingale, and I promise to do that. Next slide, please. So let me draw a distinction between measurement in the physical sciences and measurement in the social and behavioral sciences. I contend that measurement in the physical sciences is ridiculously easy. Why? Because we know truth. This is an example on the left of silver spiked into distilled water in parts per trillion. Part per trillion is a very small amount. It's 1 second in 32,000 years as an analogy. And by dilution, we create standards of, say, 200 parts per trillion, 400, 500. And you can see that analytical chemists are really, really good at recovering these with their instruments, but they know truth. In the social and behavioral sciences, in looking at cognitive ability, we don't have a way to spike you with cognitive impairment and see how well a particular measure recovers it. We're looking at a latent variable, which I denote theta in the right-hand slide. And here's an example of a single item that kicks in about the middle of the severity continuum, has good ability to differentiate high and low levels of cognitive impairment because it has a steep slope. And if I had thousands of these items, I could start to enjoy the kind of precision that's enjoyed in the physical sciences, in analytical chemistry. But I can't ask people or give people thousands of tasks. I have to be able to give them a small number so that I can then accurately assess their ability. The purpose of this talk and our work is to show that through adaptive administration of a small set of items from a large item bank, we can move the bar of the quality of measurement in the social and behavioral sciences to that enjoyed in the physical sciences. Next slide, please. So I like sports, and I like to use sporting analogies to describe fundamental ideas. And here it's important to understand the difference between classical test theory and item response theory. So classical test theory is a lot like the hurdles in the top figure. The items are like the hurdles themselves. If I change the number of hurdles in a race, or the height of those hurdles, or the distance between them, I can no longer compare the speed it takes to run a race. Same is true with a traditional fixed length cognitive ability test. If I take out some of the items or I add items, I can no longer compare the scores. The same is not true in item response theory. The sporting analogy for item response theory is the high jump. And in the high jump, the items are the locations on the bar. And not everybody has to take all locations on the bar. This individual is a very good high jumper. He's going to start at about 6.5 feet. And then after 1 or 2 inch movements of the bar, we'll know his ability. I'm not such a good high jumper. I'm going to start at a foot, build up a little confidence, and by the time I hit 4 feet, I'm going to knock the bar over. The important feature is that despite the fact that this gentleman and I have taken no 2 items, conducted no 2 tasks in common, both of our ability measurements are available in exactly the same metric. So next slide, please. So what can we do with this idea of item response theory, being able to separate the items from our measurement of the ability? We can do computerized adaptive testing, or CAT. So what is CAT? So imagine that you had a 1,000-item mathematics test ranging in difficulty from simple arithmetic through advanced calculus. And you had these 2 examinees, a lovely 4th grader and one of my poor oppressed graduate students in statistics here at the University of Chicago. Now I could go through the arduous process of giving each of them this 1,000-item test, and I'd get good estimates of their ability if they sat still long enough to take it, but it's probably not a good idea. I could take the approach that's commonly used in cognitive assessments and be able to and administer a 2-item test, a short form test, an arithmetic question and a calculus question. The child would get the arithmetic question right and get a score of 1, and my graduate student would get them both right and get a score of 2. And I'd come to the ridiculous conclusion that my graduate student in statistics has twice the mathematical ability of a 4th grader. Now, I might tell them that sometimes, but it's definitely not true. A better approach would have been to start with an algebra item, and when the child got it wrong, move to easier items, and when the graduate student got it right, move to more difficult items. That is what adaptive testing is. In simple constructs, like mathematical ability, which is a simple construct, it's essentially unidimensional, all I really need to do is to find out how far I need to move along the real line. But for complex traits, like cognitive ability, I need to find my way along a k-dimensional space. Next slide, please. This is how you do it. Don't try this at home. It's much, much more complicated than anything that has been done in the past using adaptive testing. The top alpha matrix shows that there's a primary dimension. Let's call that the global cognition dimension. And there are secondary dimensions, for example, executive function and processing speed, where the items are drawn from. And ultimately, in the 3rd equation for theta, we get a complex function that gives us an estimate of a person's cognitive impairment. And very interestingly, the bottom equation tells us the uncertainty in that estimate. So even for the level of a given individual, we can determine how much is statistically and clinically significant change. That is very, very important in the context of this presentation and this conference. Next slide, please. So what are the advantages of multidimensional item response theory-based computerized adaptive testing? That's a mouthful. We get constant precision throughout the entire range. So somebody who has very little cognitive impairment or no cognitive impairment is measured with the same level of precision as somebody who is severely impaired. The items are targeted to a person's specific level of ability or impairment. How do we know it? We learn it through the adaptive administration process. We eliminate unwanted practice effects because different questions are administered over time instead of repeatedly administering the same questions time and time again. These measures are validated against in-person structured clinical neuropsychological assessments. Screening and measurement-based care are both available. We can identify people who are suffering from cognitive impairment at various levels and also measure change longitudinally over time. The measures are cloud-based and HITRUST certified so that they are HIPAA compliant and can be administered anywhere in the world using any internet-capable device. And they're also integratable into electronic health record systems with API technology. Next slide, please. So how do they work? Well, we start out with an item that's in the middle of the difficulty continuum. And we get an answer to that item, a score. And on the basis of that, we go through those horrific looking equations and we compute the estimate of severity and its uncertainty. And on the basis of that terrible estimate, which is based on only one item response, we can select the next maximally informative item, administer that item, and all of a sudden, the uncertainty in that score has just shrunk a little bit. And we continue that process iteratively until our score has an uncertainty that falls below a threshold that we need for that particular measurement task. Next slide, please. These are examples of MERT-based CATs that we've developed for the measurement of mental health disorders, substance use disorders, and suicide risk. They're called the CATMH for adults and the KCAT for children. And what you can see is we have a wide variety of different constructs that we're able to measure very, very rapidly, typically in the order of a minute to a minute and a half for each one of these, but very, very accurately. And we also are sensitive to differences between different populations where we can optimize our tests using things like differential item functioning. So being able to look at perinatal depression or criminal justice settings or emergency departments or LGBTQ populations. Next slide, please. So with that introduction, I want to talk a little bit about the work that we're doing in the development of the CAT-COG, a computerized adaptive test based on multidimensional item response theory for cognitive ability. We have to date, with NIA R56 funding, developed a prototype CAT-COG, which we call the PCAT, which uses 57 items as its bank, each one with 3 tasks that are scored on an ordinal variable ranging from 0 to 3, based on the number of correct responses you give to those 3 tasks. The final item bank is going to have 500 ordinal items or 1,500 tasks, and we're completing the development of that now. Initially, we calibrated using 730 subjects, 646 from an online system and 84 from the Rush Alzheimer's Disease Center in Chicago, 17 of which had MCI. The average age was about 50, and we had subjects ranging in age from 18 to 101 years of age. All but one were able to complete the PCAT of all 57 items, which is far more tasking than what the adaptive test administration would be. We sampled from 5 different domains of cognitive ability: attentional control, flexible cognition, episodic memory, processing speed, and language and semantic memory. Next slide, please. This is the relationship between the observed and expected marginal item category proportions. So for each one of those 0, 1, 2, or 3 correct across the 57 items, the agreement between what was observed in the sample and what was estimated by the multidimensional item response theory model was essentially perfect. Next slide, please. This is the relationship between the adaptive PCAT, our CAT-COG, based on the 57 item bank, and age. We see that across the age continuum, there is a 2.2 standard deviation unit change, but roughly 36% of that change, or close to 1 standard deviation unit, is that final drop between ages 75 and 85. The correlation with age was minus 0.44. Next slide, please. Using simulated adaptive testing, where we simulate from the complete adaptive, the complete item bank, we're able to extract the information from the complete item bank using an average of 11 items, but maintain a correlation of 0.94 with the 57 item bank. We expect to be able to do quite similarly when we expand the bank to 500 items, but be able to enjoy even more precision. Increasing the number of items to 14, and this takes about 5 to 6 minutes, increases that correlation to 0.96. So we're extracting the information from a large bank of items using a small adaptively administered items targeted to each individual specific level of cognitive impairment. Next slide, please. We can see here by the comparison of the internet sample to the Rush clinical sample that the Rush clinical sample is very significantly more impaired than the overall internet sample. But there's overlap, complete overlap in this naturalistic setting with the same kinds of people that are in the Rush setting, in the clinical sample. So this is really important of being able to identify lots of people in the real world who may be suffering from pretty dramatic levels of cognitive impairment. Next slide, please. These are the relationships between the global dimension that we estimated in our prototype and the various measures of the 6 domains that are collected by Rush using trained clinicians. And what we see is very, very good tracking. And why does the global measure work so well? Because the multidimensional IRT is bringing and borrowing strength from all of the different cognitive domains. The effect size is enormous. It's greater than 1 standard deviation unit between those Rush patients who had MCI versus those that did not have mild cognitive impairment. Next slide, please. And this was an interesting finding. One might say, well, why did you use this ordinal measure of 0, 1, 2, or 3 cognitive tasks correct as a score? Why not just look at each one of the 171 tasks that were given? And the reason is that you can see to the left, the binary scoring actually underestimates impairment for the most severely ill patients. So there's a huge advantage of using the using the ordinal scale. Next slide, please. So differential item functioning, I know we're running out of time. So basically the idea is I want to be able to, once we develop this, look at special populations to see which, if any, items are biased in those populations. And they can be defined in terms of age and sex and race and ethnicity and education and other clinical conditions. And this technology expanded to the multidimensional base CAT works extremely well for identifying these biases. Next slide, please. Publish or perish. Over the last 30 years, we have published a tremendous amount about the statistical foundations of this technology and its applications, particularly in the area of mental health. And our work now is focusing on cognitive ability. Next slide, please. We spend billions of dollars on biological measurements, yet we validate them using Stone Age clinical measurements. We could do so much better. And finally, as promised, statistics is the most important science in the whole world, for upon it depends the practical application of every other science and of every art. Florence Nightingale. Thank you.
Thank you. Thank you, Dr. Gibbons. This was a terrific talk. There's so much to unpack here. There's so much precision, and questions are coming in through the chat that are going to be very important to address, particularly questions about practice effects and how items were selected. We'll talk about that more in the breakout session on Thursday, but I did want to ask you, because it's come through the chat and crossed some of our minds, that some of us are thinking back to very familiar computerized adaptive tests, such as the GRE or the SAT, etc. Tell us in a nutshell, if you could, the headline, how is what you're doing different than that sort of testing?
Yeah, it's a great question. So CAT has been around for at least 30 years. And of course, CAT requires item response theory. But the traditional approach to doing computerized adaptive testing is for simple constructs like mathematical ability that involve unidimensional item response theory. When you try to apply those techniques to multidimensional constructs like cognitive ability, they break down in terrible ways. They underestimate the precision. So they tell you you have more precision than you actually have. They can give you biased estimates of the underlying trait that you're trying to measure. And the CATs end prematurely before they actually reach the desired precision. We have rederived all of the equations for computerized adaptive testing based on multidimensional IRT, making it suitable for complex traits like risk of suicide, like depression or psychosis, and now for cognitive ability. It is a huge difference. It's much harder to do. And at the time when the GRE was initiated, no one knew how to do it. We figured it out.
Yeah, so valuable IRT in this work and in moving forward. Thank you so much. This was a terrific presentation. I really encourage everyone to attend Thursday's breakout session so we can unpack it some more and get into your mind a little bit more about how we could start thinking about RRT and CAT measurement. Thank you so much.
Thank you.
Our next speaker for today is Dr. Laura T. Germain. She is from Harvard Medical School, and Dr. Germain is going to be discussing very innovative ways to measure cognitive function as a dynamic process in health and in disease. Dr. Germain, welcome.
Thanks so much for the introduction and to the organizers for putting together this event, and to my fellow speakers. I know we're running a little bit past time, so I'm going to see if I can do this in less than my time, which might mean skipping through a few planned things, but I think with other speakers have set me up really well for this topic, so I think that's actually going to be possible. Next slide. So very brief history of cognitive measurement. Where are we today? How did we get here? And this is to motivate the cognitive change perspective that I'm going to talk about in this talk. Next slide. So modern cognitive assessment, I think, comes from two different traditions. One is the one that comes from psychophysics and experimental science, experimental psychology, and has really developed into modern neuroscience today, which is really thinking through what is common across people. So how do we understand the way people perceive the world around them and how they respond to it as a common process rather than something that varies between individuals. And in this tradition, control of stimuli and precision of responses and reaction times is really the most critical. Next slide. And then a parallel tradition comes from conscription of people into the military in the early part of the 20th century, which is about rank ordering people, understanding differences between people where standardization and scale are really the most critical things that you want. Next slide. So now we're in a place where I think the innovations over the last few decades have been concerned about thinking through these differences between conditions, these different mechanisms, and how they translate to differences between people. So understanding how mechanisms differ between different people to understand things like risk of dementia, of health conditions, of developing psychopathology, and just overall cognitive health. But we're now moving to a place where we have a third dimension that is newly accessible to us, largely because of digital technology, which is understanding differences not only between people and between mechanisms, but between time points. So how people change over time, not just in the traditional longitudinal sense that really takes the perspective of years and decades, but over the minutes, hours, days that we live our lives. So thinking about momentary cognition at a single moment in a single individual for a particular information processing mechanism. Next slide. So thinking of cognition, I think I really liked some of the definitions that Dr. Marquine posted as a dynamic process that unfolds both over time and in environmental context, something that we haven't really considered a lot before. Next slide. So momentary cognition is based on a lot of things, right? So it operates within a person and within a cognitive domain, but it's based on the time of day fluctuations, the place, wherever the person is, their recent activity, their health, both in general and at that moment. So health variables that are specific to that day or even that hour. Environmental influences, sleep, many variables that are fluctuating over time. Next slide. And we measure it using paradigms like this. So what you see at the top here is, traditional cognitive assessment that would happen over the course of an hour or two, but then followed critically over the next several days, up to 3 to 4 weeks we've done at this point, where we're measuring cognition multiple times a day. In this case, it's 3 times a day, hopefully across multiple domains. So the data I'm going to show you today is from 2 tests. One is a CPT or continuous performance test that gets at both sustained attention and response inhibition, and then a digit symbol matching test, which is processing speed. Now, these measures are not traditional neuropsychological measures. They have a few characteristics that are quite important. One is they need to be ultra brief. So ultra brief meaning not 5 minutes, but 30 seconds, under a minute. Highly repeatable, because you're repeating not once, twice, 3 times, but hundreds of times in some cases. And we've gone up to, at this point, about 100 times. and then with good reliability both between and within persons. So you can use these tests to look at how people differ from each other and how much, as well as how time points differ from each other and how much of that variation is systematic. Next slide. And this variation is not random. So the differences from moment to moment in the way someone performs are actually quite predictable from variables that we have available in studies like this. And in fact, using these person level variables and time point variables that we have available to us, we can predict about 35% of the variance in CPT performance and 72% of the variance on digit symbol matching in this particular sort of paradigm with about 20 time points. And I would refer you to Marty Slowinski's 2018 paper and assessment, which is a really nice summary of reliability of these sorts of assessments in this kind of model. Next slide. I'm going to talk about data from one specific study on type 1 diabetes. So type 1 diabetes is interesting because it is a disorder where people lose the insulin producing cells of the pancreas and therefore have high glucose, treated with insulin therapy, which leads to low glucose. And that fluctuation in glucose, since the brain is really glucose sensitive, means that you get a lot of cognitive fluctuations as well. So it's a disorder where there are substantial variations in cognitive function, which we can then measure and relate back to health variables. Next slide. So same sort of model that I showed you before. Here we're looking in about 200 adults with type 1 diabetes. Two of the tests that I showed you before, as well as adding now a continuous glucose monitor, which will give us readings from these patients every 5 minutes based on interstitial fluid, allowing us to link these momentary fluctuations in cognition with glucose. Next slide. So I want to show you an example of a few of the things that you can get from this momentary cognition or cognitive change perspective that you really can't get from a traditional cognitive assessing mode. So these are scores from 2 participants on a response impulsivity metric from the CPT. Higher scores are more impulsive performance in this case. The blue diamond is a baseline cognitive test score on this test, so traditional sort of assessment. And then the red dots that follow are over the next 30 time points, their scores on a very brief version of this test. The red dotted line across is the average of all those time points. So for these 2 participants, you can see that participant A, that diamond closely approximates that average. So one baseline assessment really represented the scores over the next 30 time points. But for participant B, that was not the case. That baseline really underestimated their performance over the next 30 time points. Next slide. Similarly, you see differences in variability. So here are 2 people who had the same baseline assessment score, the same mean across time points, but very different spread of scores across the 30 time points in a way that can meaningfully be related to health sort of variables, which I'll show in a minute. Next slide. And then practice effects. So Dr. Gibbons mentioned reducing practice effects, but actually practice effects are learning. They're an important source of data about how well someone can learn, how well they can improve their performance. And these are 2 participants, for example, one of whom has very profound practice effects on the right and a person who has minimal practice effects on the left. Next slide. So from this, you can get these dynamic cognitive metrics. So metrics that are individual scores from participants that are based on the dynamics of their cognitive performance over time. Next slide. So for example, what you see here is practice effects across 200 participants. So the black is the average at the group level, and then every blue line is one participant. Some people have big practice effects, some people have small. Next slide. Diurnal fluctuations. So these are differences in cognitive performance across a 24-hour cycle. Some people have very big differences, some people have minimal differences. Next slide. And then volatility. So this is basically the residual of stable variance after accounting for other factors. So some people have very variable performance over the time points, some people don't. And the value I've shown you here in the middle, this is a row of 0.7 to 0.98. This is the reliability of these dynamic cognitive features extracted from the time series data, where the time series is only including about 3 days. So you can get pretty reliable, stable, individually measured sorts of phenotypes from just 3 days of data that reflect the dynamics of cognitive processes. Next slide. I mentioned we have glucose data on these people, so this gives us the opportunity to look at the links between glucose and cognition. What you're seeing here is glucose data from one person. The purple area is high glucose, the red orange area at the bottom is low glucose, and then the blue is healthy or healthy range of glucose. Next slide. And we can take this and overlay with cognitive data. So for instance, this is the same person's scores on the CPT measure. You can see a lot of fluctuations over the 20 time points that are shown here, and one time point where suddenly they go out of their 95% range and have a very low score. Next slide. If we overlay these together, that very low score occurred right at the point that they had a severe episode of hypoglycemia, which this is a known thing. We can see in clinic studies where we manipulate glucose that people do experience cognitive impairments when their glucose is very low. But what we don't usually see is this hypoglycemia hangover. So in the subsequent time points, even though this person has gone back to normal, their scores are still lower than is normal for them over the rest of the time points. Next slide. Next slide again. So we can derive from this a quadratic curve that relates glucose and reaction time for each person based on this sort of data. Next slide. And, we have the hypothesis that people are going to differ in the extent to which they have this quadratic relationship or this acceleration, which I'm not going to use that term again because I've realized it gets confusing. So different people, some people will have a stronger relationship. So the blue and green people here, whereas others will have a weaker relationship. Next slide. And in fact, when we look at the data and we try to model these curves at the individual level, we can see that, in fact, there are people who have a very strong relationship between cognition and glucose, and people who have a much weaker relationship between cognition and glucose. So the orange person is someone with a weak relationship, blue is someone with a strong relationship. And interestingly, we saw best performance at an elevated glucose that's often considered unhealthy. So this is now, the x-axis here is glucose scaled and centered within persons. So 0 is the person's mean. People had the best performance about 1 standard deviation above their own mean, which is really interesting. Can't get into it here. But the idea is these cognitive dynamics can tell us things about where people best function. Next slide. This is interesting, right? The fact that people differ in how much cognition is affected by glucose, but is it interesting in a way that's important for health? So now we're looking at what the predictors are, and this is using a machine learning, train and test in an independent data set kind of analysis approach. What are the things that predict this relationship? So the things that we saw were neck circumference, which might seem like an odd one, but neck circumference combines both BMI and sleep apnea. So people who had a larger neck circumference had a stronger relationship between glucose and cognition. How much time a person spent in hypoglycemia, which is an important measure that's related to hypoglycemia unawareness, more time spent in hypoglycemia, more of a relationship. And then finally, microvascular complications. And these are the things that are related to stuff like vascular dementia, and people with type 1 diabetes have much higher risk of dementia. People who had more microvascular complications showed a stronger relationship between glucose and cognition than people that did not. Next slide. So, summarizing all of this, what does a cognitive change perspective give us? The idea is here that we're shifting within person variations from sources of noise to sources of signal, right? So things like practice effects, variability, these are potentially important sources of signal about health that can get us to earlier detection than just looking at mean or average performance, especially at one time point. It enables us to derive novel, clinically meaningful cognitive outcomes that combine cognitive function with health variables in a way that allows us to look at things like cognitive reactivity. We know that systems tend to become more volatile or more reactive before they have frank declines in function. And so again, potentially something that could allow us to find early indicators. And to Dr. Marquin's point in her talk, it moves us away from these norms that are actually quite problematic when it comes to equity-related issues, right? So we're in a situation where we're interpreting individuals' performance with respect to a population's average level performance. But by adding a person's own baseline into the modeling, you might really address a lot of these issues. But of course, it requires new methods, new tools, new measurement approaches. Next slide. So, I want to end on just a brief vision for digital technology and cognitive health. I think having digital tools that let us get at cognitive change offers new opportunities to engage people by thinking about patient goals and what they want to understand. It makes measures more accessible because they can be done in someone's home and therefore be added into things like basic health screenings to establish baselines that can be used for later cognitive change estimation in a dementia context. But I think the most compelling thing is we're moving into a place where we can do patient-initiated research, right? Because these devices are accessible, because people can do this in the comfort of their own home. We're in a place where people who have cognitive concerns, people who have familial risk of dementia, can initiate their own testing in a way that is not currently at all possible. And then thinking about whether that shifts ownership of data as well to patients and patient communities, and then having that be shared back with researchers and clinicians, which is very, very different to the way we do it now. And I think both the digital technology and the cognitive change approach really opens up the possibilities for this patient-initiated research in a way that hasn't been possible before. I'm going to end there. Just next slide, just to say thank you to many folks in my laboratory So as well as the Many Brains Project, which is a digital cognitive assessment organization that I run that does open source cognitive assessment. Particular people to note are Naomi Chater, who's my co-PI on the GluCog study, and Marty Slowinski, who is a collaborator in technology development. Thank you.
Thank you, Dr. Germain. That was terrific. And I remember not long ago, as a field, we were really trying to show the feasibility of older adults and computerized testing in general. Is it feasible? Is it realistic that older adults can interface with computers in a manner that could provide reliable testing? And so, to your last slide, where you described this vision, for some that are listening in on this, it might seem far-reaching that older adults can be, that these accessible digital tools can have patient-led innovations and trying to get data and bringing science and care to that degree of patient ownership. Can you tell us a little more about that? I want to perhaps ask you for a concrete example of this patient-led innovation.
So I think, type 1 diabetes is a great example of this. And in fact, myself and my co-PI on the NID funded that, both have type 1 diabetes ourselves, right? And in the type 1 diabetes community, the availability of data, because you can do every 5-minute measurement of glucose using continuous glucose monitors, is so huge that essentially a physician can't deal with it, right? Like, clinical care is managed largely by the patient, who makes medical decisions that are data informed from sensors and digital devices every day, all day. And what that has meant is, because the data ownership and the data management has been with patients, is, the first closed loop insulin delivery system that used glucose monitoring data to deliver insulin was developed in the patient community, right? So before Medtronic and other companies released their commercial devices, there were algorithms that were being shared in the patient community that were built by patients and their families to do this, right? So the availability of data and tools means that the very smart, very motivated people in the community can now build systems. They can now do analytics. They can do things that is not just something that experts like us here in this room can do, but other people can as well. And, the idea that older adults can't navigate this kind of technology, older adults have to navigate technology all the time to get care, right? If anyone's ever navigated the healthcare system to try to get care for most things, that is not a trivial sort of problem. So the idea that expecting people to use tools that are available is a higher burden or higher threshold to meet, I think, is not really accurate, given the complexity of our healthcare system and the way technology is the only interface there as well.
And in the chat, Rochelle Long has mentioned it depends upon the level of cognition, where patient-led testing might even require a dyad, right, or a care partner, a caregiver. Do you have experience with that, and has that been implemented as it relates to cognition yet?
Yeah, so my background actually comes from a lot of patient-led work. I have a platform called testmybrain.org that has now been around for about 15, 20 years, where people were doing their own testing using the freely available tools that we shared. And a big community that got very, very involved was the autism community. So not just patients themselves, but their families, people who felt that they weren't able to access the sorts of testing in the nuanced way that they wanted. So they were coming to the platform, and families were doing tests with their kids or with their loved ones. Patient communities were initiating testing themselves and then sharing results with each other online. So I think there's a huge drive to get access to information and data that is led by patients and their families. In many cases, in the case of dementia, there's going to be largely family driven, but the idea that, they don't have interesting questions that they uniquely know how to answer, I think, is one that is because we mostly speak with each other, right? Rather than with patients and their families. So, yeah.
Terrific. Other points in the chat, similar to care partners helping navigate complex healthcare system in general. This is a comparable digitally informed method of doing that.
Yeah, and different points of access, I think, is important, right? So
yeah. And the comment about smartphone use in older adults ages over 65 or 65 to 75 specifically was noted to be 71% by Dinesh John. He mentions that in the chat. So the availability, and the ubiquitous availability of smartphone technology is a tremendous advantage that certainly with certain parameters in place, the data that is acquired could be reliable, and particularly with the repeated measures. This is a terrific presentation, Dr. Germain. Thanks so much. And any other questions are welcome in the chat. We are getting ready to round out the session, or round it up and take a break in just a few minutes. And as we monitor the chat, I wanted to bring another question, if possible, to Dr. Gibbons. I wanted to go back to talking about the computerized adaptive testing approach that you mentioned in your talk. And I understand that other agencies like SAMHSA, for example, has used CAT mental health. You had listed that in one of your slides in their very nationally representative prevalence study of mental health and substance abuse in the US. Can you just tell us a little bit about that and the success of that? Can something similar be done with cognitive impairment at that scale?
Absolutely. This was a very important study, the largest study in history of mental health and substance use disorders, national probability sample, completely representative. And what they did is they used these computerized adaptive tests that measure the severity of a variety of underlying illnesses like psychosis and depression and anxiety and substance use disorders and PTSD to decide who would, in a two-stage sampling approach, then get a 2-hour-long structured clinical interview for the SCID for DSM-5. So they screened the population to be overrepresentative for people with schizophrenia spectrum disorder using these adaptive tests that were administered very quickly on people's smartphones, and then identified them, enrolled them into the studies, and then were able to, then do these lengthy in-person interviews. The same thing could be done here by doing a national prevalence study for different kinds of cognitive impairments, using perhaps as a first stage screener something like the CAT-COG that could be administered, remotely, and then doing more detailed and in-person, potentially neurocognitive testing sessions that can last hours or even a day, or just being able to use these kinds of tools in nationally representative samples to draw inferences about prevalence. The findings are now being published and coming out of the MDPS study, and one of the most interesting things is that the rate of schizophrenia is more than double than what we thought it was. So lots of really interesting things and great ways of doing kind of global health, being able to use these kinds of remotely administratable and very rapid assessments.
Great. So as the population ages, I think all of us are really thinking about ways to interface with very broad and wide scale screening methods that could be very low burden on the system and on patients. And so this seems like a wonderful method that's worthy of further research. Thank you for sharing that. All right, so I'll turn over the session. We will continue our discussion later today, and I'll turn it over to our NIH moderators. I'm also carefully monitoring the chat to make sure that we capture some of the wonderful questions and address some of the comments that are being stated throughout the chat in our discussion later today. Thank you.
Well, thank you, Rosie and Christy and Melissa for moderating, and to all the speakers. We're going to take a break now, but we will have an extended discussion this afternoon. We built in some bumper space. So if you didn't get your question answered here, or didn't have sufficient time for interaction, we'll do that after the everyday function session, which will follow here. So don't worry, we'll get into it a little bit more. So thanks everyone. Come back in, I believe, 10 minutes. All right, I have 1:10 on my end. So we'll get the meeting started right now, and I'll turn it over to Elena and Benford for the everyday function session. Elena?
Hello, everybody. I'll start with an introduction and then I'll turn to my colleague. My name is Elena Fazio. I'm at the National Institute on Aging in the Division of Behavioral and Social Research. I serve as our Director of the Office of Alzheimer's and Alzheimer's-related Dementia Strategic Coordination. Benford?
Hi, everyone. I'm Benford Williams, also at the National Institute on Aging in the Division of Neuroscience. I'm in the Clinical Interventions and Diagnostics branch, and I support our pilot programs for ADRD clinical trials.
So a few notes. This session 2, titled Everyday Function, really focuses on how meaningful change in everyday function happens, takes place, is measured. In this case, it's where everyday function is described as physical, emotional, psychological function, or social function, and how it can be understood and measured. For example, this session may consider what current measures are used to ascertain everyday function, what are their properties, limitations, future opportunities, and for whom. So we will have a little bit of Q&A time after each speaker, and then there will be a general discussion as we wrap up session 1. That general discussion, sessions 1 and 2, and that overall discussion will be for those 2 sessions. A reminder for day 3, just as a little plug, we have participant breakout sessions on Thursday following the lived experience expert panel. So join us around 11 Eastern on Thursday for those breakout sessions and that expert panel. So our session 2 here, Everyday Function, has 3 speakers. They are Andrea Gilmore-Bykowski. She's at the University of Wisconsin School of Medicine and Public Health. Next, we'll hear from Suzanne Hendricks, who is CEO of Pantera Corporation. And last but not least, we'll hear from David Sella of Northwestern University. Benford?
And the speakers for this Everyday Function session developed 2 gaps and opportunities to kick off today's discussion. The first is a research-based approach with the suggestion to develop approaches for multi-dimensional assessments, which include emotional, psychological, and social functioning. And this approach would also incorporate domains prioritized by persons living with dementia, such as maintenance of self, belonging, and engagement in meaningful activities. So overall, this approach can integrate self-reports, reliable informant reports, time savings and progression, and performance-based assessments. And the second gap and opportunity involves ongoing community input with the goal of refining and applying approaches to ensure that outcome measures are meaningful to people living with AD/ADRD. And this includes gathering qualitative and quantitative evidence from self-report and performance measures, identifying thresholds of meaningful change, and applying measures in clinical research and practice. So please keep these topics in mind during the session. And now we'll hear from our first speaker, Dr. Gilmore-Bykowski.
Next slide, please. All right. Hello, everybody. Good morning or good afternoon, depending on where you're joining from. We can go to the next slide. I'm really pleased to be here with you all today, and I'm going to try to set the stage for session 2. In doing so, my presentation is going to aim to address 2 major areas related to everyday function and clinically meaningful outcomes in AD/ADRD trials. So first, really framing some important considerations for measurement of function across the disease continuum. And secondly, considering evidence regarding the priorities identified by and with people living with dementia. And really thinking about this, I think, is a valuable perspective from which we can consider that question of meaningfulness, as our keynote this morning really helped us think about as well. Next slide. So when we think of function, we commonly are thinking of activities of daily living, and these are reliant on both cognition and behavior. These are domains that are affected early on in the disease continuum prior to the stage of dementia. These are further divided into basic ADLs, essential to independent living, of course, more commonly affected in advanced disease, and then instrumental activities of daily living, which are closely associated with executive functioning and are also very important to independence. And these tend to be more sensitive to changes in early disease, but detecting these changes reliably can be challenging. And this is especially true if we're thinking about MCI or preclinical stages as well. So this might be an area that we want to think about a little bit more in the coming days for a gap and opportunity. We didn't present a gap or opportunity on this, but there also has been discussion in the literature quite a bit about complex IADLs. And some IADL measures would include some of these more complex tasks, but thinking about the need to develop more sensitive measures of IADLs that would be sufficient at an MCI or a preclinical disease stage. So perhaps something that we will communicate about together in the coming days. So for our session, as was alluded to by Dr. Fazio, I want to really introduce an understanding of everyday function as multidimensional. And as you can see, and you will see in kind of some of the measures that predominate here, we're not necessarily comprehensively addressing all of these dimensions across measures. So this would be physical functioning, emotional, psychological, and then social dimensions of everyday functioning as well. Next slide, please. So a widely used framework that I think we can leverage to support our conceptualization of these dimensions is the WHO ICF, or the International Classification of Functioning, Disability, and Health. And the ICF really emphasizes multidimensional concepts that relate to activities of individuals, body functions, and structures. And it emphasizes participation in all areas of life, including social participation, as a major domain of functioning. So as is visualized here, functioning is both multidimensional, but it's also interactive, where an individual's functioning is a dynamic interaction between their health conditions, environmental, and personal factors. So with this framing and grounding in mind, I want to next review some common measures and what we see in their performance across the disease continuum, particularly overlaid with cognitive outcomes. Next slide. So what you're seeing here, this is a figure from a study by Doubleman and colleagues, and this used data across 6 different cognitive aging cohorts. I think Harvard Aging Brain Study, ADNI-NAC, the Amsterdam Dementia Cohort, and 2 others. And the figure shows individual and group average trajectories per clinical stage. And these are global IADL Z-scores. And these scores are derived from a harmonized measure that they generated of function, working across the Functional Activities Questionnaire, ECOG, and the Amsterdam IADL questionnaire. So commonly utilized assessments of functioning. A 1-unit change in the Z-score represents 1 standard deviation in the amyloid negative group here. So these trajectories show that at the group level, there's no decline in amyloid negative individuals, but it does appear to be present in the earliest stages of AD. Other important things that this tells us is that there's very large variability in slopes of functional decline, and decline accelerates at later stages, and stage 2 and beyond is really where decline is faster in individuals that are on the AD continuum. So this gives us some good ideas about at what stage these measures might be meaningful or useful in detecting change. Next slide, please. So this is a figure from a different study by Wang and colleagues, and this draws from NAC data. And what this figure is showing us is jointly modeled trajectories of cognitive and IADL decline, and the measure here, I believe, is the Functional Activities Questionnaire. So this again is showing us that there's considerable individual variability in the slope of decline, and they also identified these 3 different classes of decline. So the first class are individuals that have slow cognitive and functional decline. The second class are individuals with moderate decline. And it's important to note this was 2/3 of all individuals. I think there are about 1,600 folks included in this analysis. And then lastly, this is the third class, and those are folks that have rapid cognitive and functional decline. So when we're thinking about meaningful measurement, I think something we'll hopefully talk about in the coming days is how we're going to account and accommodate for the fact that rate of decline is not uniform across stages or individuals. And I think that some of our other presenters will help us in thinking about this a little bit more as well. Next slide, please. So an important goal, as I understand, of our time together is to really consider the appropriateness and the utility of different measures for detecting clinically meaningful change. So it's very useful for us to consider the assessment strategies that are used in some of these widely used measures of functioning. So there's a great publication I want to highlight by Dr. Sharon Cohen and colleagues in the Journal of Prevention of Alzheimer's Disease. And this table draws from that paper. And the paper itself is a really nice synthesis of assessment tools looking at cognition, function, as well as behavior, the latter of which is arguably really important to capacity for functioning as well. And what I think we need to recognize is that most assessment measures, again, these mostly emphasize ADL and IDL measures, are dependent on reliable informants. And this is important because we know from many studies that the correlation between self-report and informant-based report is often poor, and this can work in multiple directions for different items. So this is something for us to really think about as we progress and talk about in the coming days, particularly as we consider the high feasibility for individuals who are living with MCI or early stages and even beyond to provide a self-report of what their everyday functioning may be. Next slide, please. So here we're looking at a portion of another useful figure in this same paper, which emphasizes different functional impacts across the disease continuum. So we can consider the ways that multiple assessment strategies, including self-report and proxy report, might be useful at different stages. And I'm not sure that has really been systematically integrated across particularly longitudinal cognitive aging cohorts as of yet. We can also consider the opportunity for performance-based assessment. Maybe that's an area where people have strong feelings, but something that really hasn't been systematically integrated yet. But there are performance-based measures that are available and could be used. Of course, those take place in clinical settings, but we can think about the ways they might complement information from self-report and or informant-based reports. Next slide, please. Sorry, can we go to that? Thank you so much. All right. So I won't spend too much time here, but I want to highlight that there are other validated assessment tools, and this is just like a small proportion of them here. And we saw many of them presented by Dr. Riley earlier. So these are things I think we can consider to improve representation of those other dimensions of functioning that are not as well represented in the ADL and IDL assessments that are widely used. So this is something some of our other presenters I think are going to cover in more detail, but in particular, better representation of the psychosocial, emotional, and the social participation and social dimension aspects of everyday functioning as something that we maybe really want to consider, particularly when we want things that are going to be sensitive. And we saw, I think from Dr. Riley, some situations in which maybe there are qualitatively reported changes, but they're not being captured by measurement. So something for us to consider. Next slide, please. So I would like to transition next to thinking about the question of clinical meaningfulness. I think we're all thinking about, clinically meaningful to whom. I think it's a wonderful question for us to take very seriously and think about rigorously. So I want to emphasize that we've made very considerable advances in approaches to including and partnering with individuals living with cognitive symptoms and dementia really throughout the research process. And I think if we were speaking 15 years ago, maybe we would have more questions about how do we do this and can this be done? And I think it's so important that we emphasize that this is very feasible. And so identifying what's meaningful to people who are living with, affected by dementia is something we can do. And that's been so widely demonstrated now that we have systematic reviews reporting on synthesized findings. And I'm really just highlighting here a small section of that literature. And what I want to do to help us think about this and contextualize this is provide some highlights from a few specific studies with the goal of really stimulating questions that we might ask ourselves about the intersection between priorities of individuals living with cognitive changes and then our current measurement strategies for everyday function. Next slide, please. So in a study conducted by Huizenga and colleagues, individuals with dementia described everyday life really as a balancing act between what matters most and what can be achieved daily. And this figure illustrates some of the domains that participants in this study identified as being most important in the context of everyday life. So this included engagement in meaningful activities, maintaining a sense of connection and a sense of belonging, connection to self, and I think we can think about this as identity maintenance, capacity to adjust to changes, and cultivating a sense of openness to help and support as changes continue to occur. Next slide, please. So in a study by Finney and colleagues, also a qualitative study, they worked with individuals with dementia and identified types of activities that they felt were important in everyday life and the value or meaning that was associated with improvements in those activities. So you can see here that participation in activities both in the home and relationally or socially are represented. And there's some clear alignment here with some of the priorities that were identified and the source of meaning related to those activities with the prior study. So we see, again, connection and belonging, sense of identity, and autonomy here, as well as enjoyment and leisure and pleasure. Next slide. So as we think about what matters across the disease continuum in particular, I think there's a good opportunity for us to look at sort of common dimensions or common features across studies. And again, this is not an exhaustive synthesis, but some common features that we can identify just across this and the work by Professor Riley and colleagues is sense of meaning and enjoyment, striving toward autonomy and maintaining a sense of identity, connections with others, which I think we can understand as a form of social participation, as well as supports to adapt to changes that are experienced, are all things that are represented. And I also think it's very important that a general theme that holds true here for these findings is that across these studies, diverse representation and cross-cultural considerations remain limited. So I think I'm just about close to wrapping up here. So as we think about assessment tools that have already been highlighted, oh, sorry, next slide. We can identify that there are a few domains which are particularly meaningful as people experience progression that are not well reflected in existing measures. And I'm highlighting those here. And it's also interesting to note that in many studies, participants emphasize adaptation, accommodations, and capacity. This is really clear looking at the direct data across studies. And they emphasize this more than they emphasize deficits and losses. So I think this is something that we need to consider for our own prioritization in meaningful outcomes, especially as the disease progresses. Next slide, please. So in closing, a few more things that we might think about. The first is behavioral symptoms. These are a core feature of dementias. They're not well represented in how we think about functioning, but they interfere with capacity to function because they can be very disruptive to daily life. So I think this is something we might want to think about. It also seems important to note that many priorities emphasize sense of identity and belonging. And we might consider how social participation is a conduit for that and how that's something that we could integrate into measures, but we also need to consider variability in individual preferences and cultural values, and we haven't quite done that yet. And then lastly, many measures of functioning emphasize deficits, and this is information about change and decline, but participants or individuals with dementia have consistently across studies emphasized maintenance, capacity, and strengths. So I think that my time is up, and thank you so much.
Thank you so much, Andrea. We do have a few minutes for questions specific to Andrea's presentation. I know there is a note in chat about IADLs. I'm not sure if that's a question, but I do see that there's a question from Ian. Ian, why don't you come off mute and ask your question, Ian?
Sorry, a little slow on the computer keys. Andrea, thank you. Terrific presentation. Good to see you. Wondering in the various studies that you shared, to the extent to which you know if they differentiated by dementia subtype. So hoping that a dominant Alzheimer's population isn't washing out insights into what might be more or less or equally important, but differently important to people with a very rare form like FTD, and obviously lots of other forms out there as well.
Thanks. I think that's a really important question. I believe of the studies that I shared here, many of them are dementia broadly. So I don't think that they're the findings are diagnostically specific, but as is very common, I think AD likely predominates a lot of those. I do know that there's a nice body of literature on early onset and the specific priorities and challenges there. So I think it's a great question, but I see in your comment here, thinking about individuals who are experiencing FTD, where maybe what their slopes look like, when we looked at that NAC data and those other longitudinal cohorts, we're looking at what's happening in folks with AD pathology. So as people are experiencing different trajectories, it would lead us to question, their priorities and experiences around functioning are probably different. So that's potentially another gap for us to think about. Great question. Thank you.
We have time for maybe another question or two. Does anybody have a question for Andrea they want to vocalize? Andrea, I'll just add a comment. I know in our group conversations, we talked about disease progression, and I was grateful to see in your presentation comment and suggestions about how we should pay attention to progression of illness. Can you add anything more to that you didn't have a chance to add during your presentation?
Yeah, there are some other studies that have more included individuals with like high risk who maybe have MCI, or maybe they're participating in some of these studies where they are, sort of genetically primed. They think they're at high risk for developing AD. And I think that when we talk to people in earlier disease stages from some of those systematic reviews, and one of them maybe came up in the chat earlier, people do identify cognitive changes more. So I think as people progress and they are struggling with some aspects of daily life, the data, if you look at the quotes from these studies, there's a little bit of acceptance and thinking about accommodation a little bit more heavily than from these other studies where there's more inclusion of people who maybe have MCI, who maybe, are amyloid positive and are participating in these other, some of this data is also coming out from some studies about disclosure to study participants. So I think that, priorities change. I haven't encountered a study that's systematically looked at this question with people very well characterized, at every stage of the disease continuum. But I do think it tells us that when we think about measurement, we need to appreciate that we're maybe not measuring some things that matter to people who are experiencing difficulty in everyday life, that there are other aspects of functioning and things that they are interested in preserving that are just not captured in what we're looking at. So when we think about sensitivity to change at those stages, that might be something for us to consider.
Thanks, Andrea. And we're going to go ahead and move on to Dr. Hendricks. If anybody has additional questions for Andrea, please bring them up during the larger discussion. Suzanne?
Thank you so much. So I will give just a brief introduction. I've worked in clinical trials for over 30 years, and specifically in Alzheimer's disease for the last 20 plus years. And I have a team that does statistical consulting in this area. So a lot of what I'm talking about in my presentation today will be based on the work that we've been doing together. Sam Dixon and Craig Mallinckrodt are two of my team members. So next slide. We consult dozens of companies in the neurodegenerative space, particularly in Alzheimer's disease, and still have those disclosures. Next slide. So just as an introduction, we've seen dozens of studies in progressive neurologic diseases, some of which are rare, that have missed significance on their primary outcome, but slow down the progressive outcomes of disease. In many of these studies, they didn't have prior data to assess the outcomes that would be the most progressive. And inevitably, they show the strongest effects on the most progressive outcomes. And that makes sense because that's where you'd be able to detect those differences. Often, before the study even started, some of these categories were collapsed to be able to have better meaningfulness between the individual categories. But that also introduces some noise and some variability that makes it harder to see true treatment effects when they are there. And in fact, trying to measure things less discretely just makes it so that you're measuring the effects less precisely and have additional variability that you've introduced. The integration of evidence across outcome measures to measure progression is a better approach for treatments that affect all aspects of disease. And the work that I'm going to be showing today is based on an assumption that you're measuring a lot of different aspects of disease, many of which are functional, potentially cognitive, maybe behavioral, global as well, that could include any and all of those. And that by putting all of these together, you can get a better assessment of whether the true disease progression is actually being slowed down. Next slide. So first I'll talk about what is disease modification versus symptomatic effects. And even though this is a construct, it's actually really relevant to this conversation. Challenges of degenerative diseases specifically, and then combination outcomes and ways to put these scales together, and then how to actually measure time savings. Next slide. So a perfect outcome would progress consistently across the disease. Every minute you're in the disease or every year you would progress by X number of points, and that would be constant across the disease. If you were measuring things very precisely, you could do that. And essentially in that case, what you're trying to do is say each of these points represents a specific number of months or number of years of progression in the disease. And of course, we have no perfect outcomes that do this, but within different stages, we have some that maybe could perform in this sort of a way. Next slide. This shows just a diagram illustrating what symptomatic effects are versus disease modifying effects. And I'm in favor of all treatments that work in Alzheimer's disease, symptomatic and disease modifying. And ideally, we would find outcomes that, or we would find interventions that achieve both of these types of effects and potentially use them together. So the blue line here represents a placebo or untreated population. The red line represents what a symptomatic treatment does, which is that it gives you a benefit immediately when you take it. You maintain that benefit while you're continuing to take the treatment. And then if treatment were removed, you would lose that benefit and go back to the blue line. A disease-modifying therapy is one that's believed to actually slow down the processes, the biological processes that are building up and making the disease progress over time. If you slow it down, then it builds up more slowly, and that slowed rate of progression reflects the true progression in the disease. If you come off of that treatment, you would then progress parallel to the blue line. Next slide. So we talk about symptomatic effects as being vertical effects or point benefits. We're measuring things on a clinical outcome scale, a functional scale, or another type of scale. And these points of difference are things that are directly symptomatically related. And it has to do also with the earlier conversation around measuring effect right when they're having it. Next slide. And with a disease modifying effect, we're pushing people to a later stage of disease or prolonging the amount of time that they're in an earlier stage of disease. And this looks like a horizontal effect where the time progression that we see in the blue line is then pushed later and they go on a slower rate of progression while they're on treatment. Again, if someone were to come off of this treatment from the green line, they would be expected to progress parallel to the blue line from that point onward, meaning that the position that they look like they are in the disease is the actual position they are in the disease. They would progress as a normal individual from that point onward, meaning an average individual from that point onward. With symptomatic effects, your treatment is given and has a benefit while it's there, but as soon as it's taken away, the participant would go back to their regular stage of disease and look just like they had if they had never been treated. Next slide. So our goal in this case is to have tools in place that can help us identify disease modification when it's happening. As I mentioned, I'm still in favor of course, disease modification and symptomatic effects, but this time savings concept specifically lends itself to disease modification. Disease modifying therapies affect multiple aspects of disease. And if you're really slowing the overall progression, it should be all the aspects of disease. It's harder to modify the whole disease than to affect only one symptom. And I think that's why we have symptomatic treatments and usually identify them prior to disease modifying therapies. For degenerative diseases, disease modifying therapies are critical. And right now, the hurdle for disease modifying therapies is higher than for symptomatic therapies. And defining clinical meaningfulness tends to focus us on the symptoms and the points on each of these scales, not necessarily the overall progression of the disease that's happening and driving each of these different symptoms. Next slide. So the underlying disease can be moving outcomes of global performance, cognition and motor performance, function, and ADLs. All of those can be driven by this underlying disease. Next slide. So one of the challenges of disease modifying therapies in rare degenerative diseases, but also a challenge in just Alzheimer's and related diseases, there are often no established validated scales with known progression rates. It's difficult to choose one pre-specified primary endpoint. And I would argue also that a lot of the conversation we've already had about aspects of disease that we're not really measuring relates to this, that there are outcomes that we should be measuring as well. These diseases are often multifactorial. Several aspects of progression are known and measured clinically, but this introduces a multiplicity issue if we measure each one separately and assess them individually. We need to treat patients early enough to have a treatment effect, but late enough that we can measure progression, and this sweet spot differs by the outcome. And in fact, often these diseases need to be treated before the symptoms meet established symptomatic definitions of clinical meaningfulness. So when we get caught up in a 2 or 3 point change being clinically meaningful, sometimes these participants aren't even changing by 2 or 3 points in 1 or 2 years. And so the disease itself is essentially not clinically meaningful by some of the standards that we might set. Next slide. And unless we wait till later disease. So people think that if a treatment works, it will show significance on all of the clinical outcomes at an alpha of 0.05. But this is only true if they're all highly correlated. If you have 2 perfectly correlated outcomes and they both are required to meet that significance level, your overall alpha would still be 0.05. But in neurodegenerative diseases and specifically in Alzheimer's disease, the different aspects of progression are often mostly independent or uncorrelated. Our correlations in a 1 year to 18-month study would be something in the 0.3 range. And 0.3, if you square it, is 0.09, which means 9% overlapping and 91% uncorrelated or unoverlapping. So requiring significance at a 0.05 on uncorrelated endpoints or confirming a primary outcome with a secondary outcome is equivalent to using highly strict alpha of 0.001. 0.01 is considered highly persuasive. This is a stricter standard by an order of magnitude. So to have a fair assessment of multiple outcomes, either we need a less strict alpha for each outcome, or we need to use a combination outcome. Next slide. So these are a couple of ways you can do combination outcomes. There are composite scores that have been derived to measure the most progressive aspect of disease. Some of these might be something like ADCOMS or the IDRS. ADCOMS was specifically optimized for progression. Global statistical tests are another way to do this, and that is to combine scores statistically using ranks, percentiles, or z-scores. And it's a way to measure overall evidence of efficacy, but there are some interpretation challenges. People can't always interpret a z-score as readily as they can points on a scale. But one way of making these GST outcomes interpretable is to translate them into time savings or prolonging the disease progression. And that makes these outcomes better to be interpreted. I noticed in the early presentations, there were a lot of phrases alluding to the fact that individuals who have Alzheimer's disease are really interested in this concept of time savings. I saw words like continuing to perform a certain level, keeping interested, being at a certain state of disease, maintaining functions, retention of performance, keep doing things, keeping your identity. All those kinds of things are this idea of prolonging the early stages and being able to slow down the progression to later stages. Next slide. So when we do a combination endpoint and we combine 2 or more outcomes into a global statistical test, GST stands for global statistical test. If we add 2 together, it may be that adding a second p-value could weaken the primary endpoint. It could be supportive of the primary endpoint if the p-value with both together is similar to the original one by itself, or it might strengthen the primary endpoint. And it depends on how strong it is and how correlated it is. A similarly strong endpoint that is not very highly correlated actually strengthens the evidence quite substantially. Next slide. So this shows an example from Reata's Friedreich's ataxia study where mFARS was their pre-specified primary outcome, and the PGIC and the CIGIC were 2 of the key secondary endpoints. And you can see that the p-values for PGIC and CIGIC were 0.125 and 0.520. When you look at that, you think, well, the primary was significant, but I'm not sure those secondary endpoints are actually supportive. When we put all 3 of these into one global statistical test, the overall p-value is 0.012, meaning that both of these outcomes together actually strengthen the evidence compared to mFARS alone. Part of the reason for that is that these are not that highly correlated, so even falling on the same side of showing a treatment benefit is already adding to the evidence in some way. So more evidence with all 3 of these, even though the 2 secondaries do not look like they're really confirming the same result. Next slide. Then we also did an analysis where we took the mFARS, which was pre-specified primary, and also an ADL scale that was believed to be really clinically meaningful to participants. And in this case, we're combining a 0.014 with a 0.042. And these two together, again, because they don't have much correlation, gives a much stronger p-value of 0.004. Next slide. This now shows a simulated data set. It's a fake data set with highly correlated endpoints. And what it shows is if you have all these different outcomes and some are in favor of active over to the right here, some are not in favor of active to the left, and we see this big spread of outcome measures and how significant they are. If we put all of these together and they are highly correlated, the overall evidence would not be statistically significant because it's just leaning a little bit to the right. And if they're correlated, they're all measuring the same things. And these are just each different iterations of the same statistical test. Next slide. This shows exactly the same points, but assuming that they are minimally correlated. And if they're minimally correlated, then having that many of these outcomes fall to the right-hand side in favor of active is actually highly unusual and would result in a highly statistically significant combination endpoint when combined across all of these. In Alzheimer's disease, this is really relevant because we expect the CDR sum of boxes, ADCS-ADL, and ADAS-COG to be consistent with each other in a clinical study. But in reality, because they're not that highly correlated, getting a p-value of 0.04, 0.08, 0.12 would actually still be quite substantial evidence in favor of a true treatment effect because they're not highly correlated and they're all directionally consistent and trending toward a similar effect size. Next slide. So when we evaluate the integrated evidence within a clinical study, one way that we often recommend doing this is ordering the outcomes based on the pre-specified hierarchy that was specified in the protocol and the statistical analysis plan, and then calculating the cumulative level of evidence based on all prior outcomes. So at each point, you can say the primary outcome is significant at 0.04. When we add the first two together, we have 0.01. When we add the first three together, maybe we lose a little significance, 0.03. And you could do that at each step to see whether each additional outcome is adding or subtracting from the evidence you already have. And in fact, when you're interpreting results, when people are looking at results from a clinical study, they're doing that in their head already, but they're usually doing it without information about the correlations. And so when they see something that's a 0.04 and then something else that's a 0.10, they might think that's subtracting from the evidence. And it may be if they're highly correlated, but it may actually add to the evidence if they're not that highly correlated. Another way that we recommend doing this is to rank outcomes according to the sensitivity progression, with the idea that the more progressive the outcome is, the better chance it has of showing whether you've slowed disease or not. And then again, calculating the cumulative level of evidence with each outcome. And I'll show what that might look like on the next slide. Items that have categories, oh, sorry, go back one second. Atoms that have categories collapsed to be meaningful are often highly variable. And this is, again, that idea of if you make the scale less precise to begin with and collapse points to be bigger jumps between the points, often those collapsed scales make large changes look small and smaller changes can look large. So they just add additional variability without really achieving their goal of making sure any effect would be clinically meaningful. Next slide. So this shows what it might look like if you put the most sensitive items first and the least sensitive items later. Mathematically, more sensitive to progression items will give you a better chance of showing a treatment effect, but there will be some variability in this. And so you might get this combination of outcomes where you see the biggest effect in the most progressive items, and the items that don't progress very much don't really have a chance to show progression, because if you prolong the time in that stage by double, but they only decline by a tiny amount, it's still a tiny amount, even if it's twice as long. And this shows then that you could combine the evidence again at the bottom, and we would ideally put p-values down the side to show how much evidence you have at each step of this list of items. Next slide. So time savings, and time savings is this idea of prolonging a stage of disease, maintaining function, keeping your current function, retaining your relationships, retaining your identity. True disease progression can be measured against time as a gold standard, and time is a natural gold standard in progressive diseases because the progression of it is really what makes these diseases so devastating. Next slide. So all outcomes, in a sense, are surrogates for disease time. Time and disease progresses linearly. A person would progress 1 month of progression with each month of the study. The disease accumulates as the biological process causes damage. The mean to standard deviation ratio of the change score over time is the best indicator of how good each of these outcomes is as a surrogate for time, because it's just the signal to noise ratio of the change from baseline in the outcome. Next slide. Time savings or progression savings is inherently meaningful to patients, families, and clinicians, and is the amount of progression in a disease that is delayed by a drug and corresponds to preservation of function in earlier stages of disease. Next slide. So if a progressive disease declines linearly, then you can talk about percent slowing. 100% slowing means that you would have an active arm that's completely flat. 50% slowing is shown with the green line, where it's exactly halfway between flat and the placebo decline in the blue line. 33% slowing is shown with the orange line. Next slide. So that's the previous slide showed points. This one shows time. If it's linear, they end up being the same. And here we show that same green line and show that it's 50% point savings, but also 50% time savings. And the orange line is 33% point savings and also 33% time savings. In this case, if it's a year-long study, it would be 4 months saved out of a year of observation time. And what you're really asking is, at what point was the placebo group at the same point that the active arm was at the end of the study? And the answer is it's 4 months earlier, meaning that the active arm has not progressed that last 4 months during the same 12-month time period. Next slide. If you have a proportional, if you have an effect that's actually curving downward, or an outcome measure that's curving downward, where you have really slow change initially and then faster change as the disease moves on. Many of our scales have this in early disease. If you have that, then the blue line here represents the placebo group with the curvature. If you change that, if you have a proportional reduction of 50% all the way across, that turns into the red line. But the green line shows what it looks like if you prolong the disease by twice as much time, instead of just reducing the symptoms by 50%. And what that does is it says that that early stage where you're on the flat part of the curve lasts longer. And because that lasts longer, doubling of the time actually corresponds to a much stronger effect on the scale. And it's more like a 75% reduction in the symptoms. Next slide, which argues for earlier treatment. This is showing the ADRD for the donanemab phase 2 study. And what it shows is it was a 76-month study, 76-week study. We draw a dashed line backward from the end of the active arm to the placebo and ask at what point was the placebo at that same point. It was at 52.5 weeks, which corresponds to a 5.4 months time savings. We do the same thing with the error bars above and below that same estimate at the end, and we get standard error estimates around that time savings. And this is a way to just directly translate something like an IDRIS or a composite score or any outcome measure into how much time you've saved. Next slide. This shows that if we have 3 different outcomes, this might be an ADAS-Cog, an ADL, and a CDR sum of boxes, and if you convert them each to a time savings, you can then put all of those time savings estimates into one overall time savings estimate, with the idea that if they're having similar effects, that saving time within each of these could indicate a true underlying time savings that's happening and influencing all 3 of these outcomes as different symptoms of the disease. Next slide. A composite score can be interpreted as time savings, and outcomes with the best mean to standard deviation ratio are the most relevant and can be combined in global statistical tests. Time savings can then be directly calculated and combined across outcomes. It's easy to interpret for families, patients, and clinicians. Next slide. We need to give disease-modifying therapies a fair assessment of efficacy. Right now, the hurdle is often 10 times higher than a highly persuasive standard. And as we move in the Alzheimer's field from symptomatic benefits, which we hope we still get more of, and we hope we still identify further ways to improve symptoms. As we move toward more disease-modifying therapies, we need to be able to measure things better, even in the early stages where studies can be very small. And in early stages of disease where changes are very small, and we really want to prolong those early stages. Using global statistical tests and composite scores can address this problem and allows measurement of the true gold standard of progression time. Months saved of progression with X months of treatment is a natural metric for degenerative diseases. It's easy to understand and has inherent meaningfulness for stakeholders. Next slide. So clinical meaningfulness has often been defined on a scale level using points, but should also be interpreted directly by patients and families using time saved. Once we know the time savings, this benefit can be weighed directly against risks, and you could ask families and patients whether a certain amount of time savings is worth the risk of a specific type of intervention. For one patient and family, time savings of 50% might not be meaningful, but for another, prolonging the current state of disease twice as long might be meaningful, or potentially 75% time as long if you're on that flat part of the curve. And it would be meaningful for us to be able to ask this to patients and families, knowing that things like keeping their identity, continuing to do things, retaining function, maintaining their performance are all goals that are important to them. Thank you so much for your time.
Thank you, Suzanne. If you have any questions on that presentation, please include them in the chat. We'll also have some time to go back to questions during the general discussion. And now we'll move on to our next presentation by Dr. David Sella.
Says I can't share my screen until someone stops sharing. Okay, thank you. Okay, so thanks everyone. I'm going to back up a little bit. I'm Dave Stella. I'm a professor at Northwestern University, and I want to recognize my colleague Devin Pipert and also Jeff's phone in memoriam. Jeff provided data that I'm going to show a little bit of, and Devin is a colleague that works with me on this issue of understanding how to articulate meaningful change. I'm going to sort of make this a relatively straightforward presentation about simple steps toward identifying the meaningfulness of a measure. And I'm going to just cover 3 simple steps: content verification, anchoring the measure to other similar measures, and then show a prospective demonstration or so-called validation of a measure and evidence for its meaningfulness. So in terms of content verification, we want to demonstrate that the content, that is the items in a measure, are meaningful to the target population. And that usually requires qualitative methods, often referred to as concept elicitation. And then we want to make sure that those items are assessing what we intend for them to assess, sort of the underlying concept of validity. We typically confirm that with debriefing with people, again, with the target condition in hand, to make sure that they're understanding the questions or the items in the way that we intended them. And then we reconcile that measure, if you will, with the literature. And that really is the first step toward being confident that you have something that's meaningful. I was asked to do this because of my association with PROMIS and NeuroQual and the NIH Toolbox. And this is just an example of the PROMIS domain framework. It covers self-reported health, as does NeuroQual. NIH Toolbox covers a wider range of health, including cognitive function. But self-reported health, we divide into the WHO classes of physical, mental, and social health with articulated dimensions or domains out to the right of physical, mental, and social health. And it's fairly large. This is just PROMIS. So there are over 3,000 items in PROMIS, and they represent or comprise nearly 200 banks or scales or pools of questions, and 166 domains, which I highlight because when I took a look at Professor Riley's article, I wanted to see the extent to which PROMIS would cover those domains, or any of the health measures covering those domains. And looking at Professor Riley's 13 core outcomes, we actually only cover 5 of them. So I went in confident that we have a pretty broad coverage because of having between PROMIS, NeuroQual, and health measures, really well over 200 different domains of life covered. This particular work with Professor Riley's identified some areas that are actually not covered by these tools. So that may be an important thing to to talk through as to how we address that. The second basic point I wanted to talk about is anchoring the change scores, because when we when we're talking about meaningful change, we need to make sure that it's there's some way of demonstrating that. First step is to identify a suitable clinical or person-centered anchor. And, we want to make sure that it has a conceptual relationship to the measure, that it passes the sort of face valid sniff test, if you will, and that it has a statistical relationship to the measure. We're willing to go down to as low as a correlation of 0.3. Some have recommended wanting to see those correlations be more like 0.4 to 0.5. And we also engage when possible and increasingly in some sort of bookmarking or standard setting exercise, which we pulled from educational assessment in the tradition of item response theory that Professor Gibbons gave an excellent lecture on. And we use these exercises to help identify experts, and by experts I'm referring not just to clinicians, but also to patients and family members, their score values for thresholds such as what constitutes mild, moderate, and severe. And we can use vignettes of each of these domains, domain continua, to provide case vignettes that people can then say, well, that would be a mild case of impairment, that'd be moderate, and this would be severe. So we're interested in who changed and how we know they changed. And this really is kind of just the basic, laying out the basics of this. So there are some potential ways to know if someone has changed on an outcome. First, there is this meaningful change concept, which really relies on anchor methods. People do use distribution-based methods to at least start to estimate what might be meaningful, although distribution-based methods in and of themselves don't confer any meaning. And then there's the issue of statistically significant change to make sure, or at least test whether or not the change that you're measuring exceeds measurement error. One example being the reliable change index, but I'll show some others. But it's also important to ask who's under consideration. If you're looking at the meaningful change of a group, that can be quite different than the meaningful change of an individual. It tends to be considerably smaller on a questionnaire or test. Now, the FDA has provided guidance on this going back three plus years ago or 4 years ago, saying that distribution-based methods like effect sizes and proportion of the standard deviation or standard error of measurement do not directly take into account the patient voice, and as such cannot be the primary evidence for within-patient clinical meaningfulness. That's a position that most of us agree with, not only for that reason, but also because they can be somewhat misleading and fairly arbitrary, and there are various ways that people do it, and I'll come back to that. But the guidance does focus on using the average change for patients in a study as to who in a particular study improved or got worse. And again, this is something that Professor Gibbons alluded to. We don't really ever know if somebody got better or worse. And if you try to use something like the PGIC, the patient global impression of change, it's a flawed approach because the patient's global impression of change is overly influenced by their current status to a point of bias that would lead us to not want to use that in itself as a primary endpoint. So we tend to anchor the change score in an outcome assessment of interest to some other measure of change. We can use the patient global impression of change as an anchor. It's a very useful anchor for that reason, because it does tend to correlate, again, in that 0.3 to 0.5 range with an actual change score, even though it is influenced by your current status. And then, so some examples of that are mean or median change methods that look at the difference in change scores between those anchor categories, like the difference between somebody who says they've improved a lot compared to someone who says they've improved a little, which is also in turn compared to scores of someone who says they've stayed the same. As I mentioned, there are several different measures of statistically significant individual change. I'm going to focus really on a couple of them. Sorry, I'm getting a pause in my advancing. There we go. I'll talk about reliable change index and its associated coefficient of repeatability and standard error of measurement, which is the standard deviation times 1 minus the reliability. Often people use Cronbach's coefficient alpha for that purpose. But I'll give an illustration here on a paper that looked at clinically meaningful change in quality of life associated with atrial fibrillation to illustrate some of the problems of statistical approaches in and of themselves or used in isolation. So here's an example of a test, the quality of life atrial fibrillation effect on quality of life test, where prior research had suggested that a 5-point change would be meaningful. However, the standard deviation of 17.8 with a coefficient alpha of 0.9, which is actually a very reliable test, produces a coefficient of repeatability of 15.6 based upon that formula that I showed on the previous slide. And that means that the coefficient of repeatability is 3 times the anchor change threshold, that being what would be considered a statistically significant individual change is quite a bit larger than the anchor-based estimate. So it leaves one scratching one's head. So what's the problem? Well, if the anchor-based change threshold is below that coefficient of repeatability, we may not be able to be very certain, at least statistically certain, that the individual's change score was not due to chance alone. So individual change scores, because individual change scores are quite noisy, I guess, what I'm suggesting is we probably need to think beyond the 95% confidence interval, which is what the reliable change index uses for deciding that this change is probably beyond error. Because ultimately we care about meaningful change, and we want to know that the observed change is not due to chance. We also want to be able, I would argue, to classify as many people correctly as possible. Meaningful change and significant change really are relatively independent of one another. They can be perceived as alternate approaches, but we often want to know both, and we do look at both. So the question is, can they work together? What can we do about that? And that's where the illustration comes into play on this prospective demonstration. I'm going to introduce this term of a likely change, which is really a reliable change index with a relaxed confidence interval. Because reliable change index at 95% confidence produces thresholds that are usually much higher than what an anchor-based method would suggest is meaningful to patients. And so that creates the conundrum. We may not need to be absolutely certain, or at least as close to absolute as possible with p.05 thinking that the observed change is not due to chance alone. So we can do that, of course, by relaxing the p-value. And as 1.96 is the critical value that corresponds to a p-value of 0.05, you can use lower critical values. So associated with the p-value of 0.32, which is 68% confidence, you get a critical value of 0.994. And similarly with the p-value of 0.5, you can get a lower critical value. So we published this paper suggesting that we could compare how critical values of p.05, 0.32, and 0.50 could categorize, in this case, using Jeff Sloan's data that I mentioned earlier, cancer patients that have deteriorated with anchor-based methods on the PROMIS physical function short form. And just to illustrate that, so anchor-based approaches have suggested 4 points is probably a meaningful change on the PROMIS physical function short form. But using different critical values there on the left, the 95% reliable change index requirement would be 7 points. The 68% would be 4 points, and the 50% would be 3 points. And you'll notice that the kappa is bolded down at the bottom of each of the boxes. Here, the kappa is really perfect for the 68% 4 points. So it's just an example of how by relaxing that critical value, you can justify getting closer to correct, so-called accurate classification in correspondence with the predetermined anchor-based estimate. So it's a complicated process. Multiple sources of information can be useful. These anchor-based methods are important, and they're important to include the patient's voice. But measurement error, if you look at most examples, can frustrate your efforts to find meaningful change because if you focus only on measurement error with a 95% confidence interval, you're going to be saying lots of people that actually have changed, for the better or worse, are classified as unchanged. And so I think, we're advocating that, you can determine which approach makes sense to you in defining individual change by, in some cases, tolerating less certainty for this likely change index. For example, if you're screening for drug toxicity in the early evaluation of a new treatment, you might want to relax that, that criterion, and yet you might want to keep it at 95% confidence if you're allocating a new treatment that's only appropriate for people that experience, clinically severe issues. Thank you very much.
Thank you so much, David. We're going to spend the next few minutes entertaining questions that may have come up for you all specific to Dr. Sella's presentation, and then we'll move to a more general discussion and Q&A. Anybody have questions for Dr. Sella about his presentation or his work? I'm curious, David, in sort of the history of PROMIS, and I have to admit, I didn't realize, I think you said there was like 3,000 items. I'm wondering what you find most interesting about PROMIS as it could relate specifically to the dementias.
Yeah, we developed PROMIS to be comprehensive and inclusive of physical, mental, and social health, including symptoms and function. So as I said, I went into that exercise that I just did after seeing Professor Riley's paper, thinking that we'd have pretty good coverage, because we have had pretty good coverage in most clinical areas where we've gone. But perhaps this is an area where there are some special needs or special issues. I go back to that cartoon that I thought was really wonderful about all of the good parts of life that someone who's lost memory and cognitive function can have and don't want to be forgotten. It was really compelling. I don't, PROMIS was not developed for people with dementia. It was developed for people with a host of other chronic conditions. So it's really given me pause to think about how we can adapt. Now, certainly there are aspects of PROMIS and NeuroQual, for that matter, that do address some of the important issues. They just don't address all of them.
Yeah, and I'm guessing, Robert, Dr. Gibbons, you probably have a question. Could you go?
Thanks, Dave. Good to see you, and great presentation. I'm having looked at some of the statistical approaches, it occurs to me that one approach that might be interesting to consider is that if you have a CAT-based procedure where you're fixing measurement precision, and I know many of the PROMIS measures do, then we could use that posterior standard deviation, either that or its 95% confidence interval, which is just 1.96 times that thing, to describe at the level of the individual what would be meaningful change. And given that we're using CAT and everyone is going to have the same posterior standard deviation or close to it, then that might be a good, anchor point to say, this is what clinically, meaningful change is. In some of our CAT, like CAT depression, it's 5 points on a 100-point scale. So, more than 5 says there's something going on, and more than 10 means there's something going on. It's statistically significant. So I was just curious about your thoughts.
Yeah, no, that's a great thought. It's a good idea. I mean, it's particularly in the middle of the distribution, with the standard errors getting so small with the CAT. We can probably not have to relax that coefficient of repeatability and keep the p.05, which I think will satisfy more people than me trying to convince them to relax it down to p of 0.32. Because I've always focused, Robert, on wanting to be right the most often. And if you want to be correct the most often, you don't want p of 0.05. With most measures, you're gonna have to relax it if accuracy is your goal. It's just certainty is your goal, then of course you want to have that higher p-value. So I think you've put forward a good idea there, and we'll go back and look into that using that posterior distribution and standard error. because I think particularly in the middle of the distribution, we'll get, we'll have some pretty good confidence.
Great, thanks.
Siobhan, I see that you have a comment for David in the chat. Is that something you'd like to add to?
Yeah, hi. No, David, that's amazing that you managed to do a bit of a dive into the health measures net and the promise. I know nothing about this, so I'd only had a little look. But the fact that you've just had a look for the 13 items is amazingly quick. So well done. But bad news that there's nothing really that captures all 13, but not really surprising.
Yeah, I don't know if you're finished with your comment.
Yeah, I am. Yeah, that was it. Just well done.
Yeah, I was. As I said, I went in confident. I came out quite upset. Like I didn't realize we could have missed so much. And unless you stretch it and say, well, having a laugh could be depression. Your depression could be the flip side of having a laugh. But there's no question about having a laugh. For example, in those 3,400 promise items or the NeuroQual items. And again, it brings me back to that cartoon. The things that can still be enjoyed in life. Promise and NeuroQual are both guilty of focusing on the negative. I think that's been an issue in measurement pretty much as long as we've been doing it. We focus more on the bad things than on the good things. And many of those things that you are in your core set are retaining the positive.
Absolutely, and I think that's just consistent across the literature that we looked at. So it's very, very consistent, unfortunately, but it means that we now know we really need to do something about it.
Well, the whole positive health movement, it's had its advocates over the years, but still, I think needs, maybe this can be a moment in time where we infuse it with more commitment to develop positive outcome measures.
Absolutely. Well, thank you for your work. Thank you.
Do we have any other questions? Oh, I see Michelle Campbell has a question. Please go ahead.
Good afternoon. I'm Michelle Campbell from the FDA. Hi, Dave. This isn't necessarily a question directed to you, but I do know that you would have some thoughts about this in measurement in general. And it ties back to something that Andrea said in her presentation about exploring other outcome measures. And as you know, for the FDA, we look at 4 types of outcome measures, not just the patient-reported outcome. And so I was hoping, and you can start, Dave, or we can defer to the other panelists who have presented today on how maybe perhaps address some of our unmet needs in measuring meaningful change in an ADRD population is leveraging non-patient reported outcomes, because at some point reliability of the patient is going to become a factor. And I think, I know we've had these discussions before. When is that line? It's a very hard line, and it's true in many diseases and disorders. But thoughts about how do we look at clinically meaningful change from those other aspects of outcome assessments, caregiver, clinician reported, and the performance outcome measures, which I do think performance outcome measures is maybe something the closest we can get sometimes to what a person can do if they can't self-report.
Yeah, happy to let others chime in, but maybe I'll just comment on the caregiver side of it. The observer reported outcomes. It's complicated because, of course, caregivers have their own burden and their own emotional response to what's going on, and that can color the way they reflect on the well-being of the identified patient. But it's such an important area to get that input, and I think there's really no substitute for the caregiver's input. Clinician reported outcomes, I don't cover it, and then as you point out, the self-report is not going to do well. I mean, there are plenty of performance measures that are already in use, certainly on the cognitive side, and we've been hearing about that. But I'd love to hear what others have to say about this.
I can add a thought. I think that it's a really important question. And I think something that we can consider is there's going to be a lot of fluctuation, even within a day and day to day, that in dementia specifically, that I think gets overlooked. And we're often looking for like that line, like when does the capacity stop? And capacity fluctuates. And that's a normal characteristic, of dementia. So there's that. And then I think it depends on what you're asking people. And an interesting body of literature that I think could be inspiring in this particular domain is assessment of pain in individuals with cognitive impairment, including with limited cognitive ability. So many validated tools have been developed that integrate observational measures, but also strategies to ask people about pain, which it turns out people can do reliably quite a ways into their disease process. So I don't know that we've investigated that as rigorously when we're thinking about things like function. And then I just wanted to make one other comment about, if I could, how do we think about these other measures? And I think Dr. Markeen had a really astute comment in her presentation about different disciplinary foci. And I think that's another opportunity for us, because there are disciplines, I'm speaking as a nurse here, that maybe encounter someone and the first thing they're thinking about is, what do you still have? What are the abilities that I'm working with? So, nursing, OT, PT, these might be some disciplines with that perspective. And then we also need disciplines with other perspectives that try to understand the deficit. So like a combination of these things might be useful for us to think about with this question of how do we get to thinking about other measures and get to finding that timeline. That was a great question.
I think at this point, we're going to go a little bit back in time and see if anybody would like to ask the questions that they had over the course of session 1 and 2 that maybe were in chat, but we didn't have a chance to answer on screen. So I would invite folks to consider that, but first I'll turn things over to Luke.
Yeah, so thank you. So there have been several questions in chat. If the speakers and moderators from both sessions 1 and 2 could come back on screen. If you have put a question in chat and would like to elevate it, please raise your hand in the chat window, participant window. I'll defer first to moderators. So Rosie, Melissa, and Christy, and then Elena and Benford. If you have selected questions that you'd like to bring to the group, especially questions from the cognition session, we didn't have quite as much discussion there. And then more importantly, any cross-cutting topics that came up across both sessions. So maybe Rosie, I'll start with you.
All right. Maybe this is cross-cutting. I'm going to do my best to try to articulate what's kind of speaking loudly in my head. And it takes us way back to a comment made by Dr. Cummings. This, as we try to better articulate together what is meaningful change, we've heard and agree that meaningful change is what's meaningful, for the patient and family. So defining what's meaningful for the patient and family, but also what's meaningful as a treatment outcome that would show disease pathology modification. So scale level points on objective cognitive tests, for example, this is where the clinical trialist or Dr. Cummings might be at. And then is there an intersection of both? So I thought Dr. Hendricks's presentation was a wonderful opportunity to really explore things like time savings as an important, perhaps, intersection of both of these priority areas. So perhaps we could start off there. And David, you have your hand up.
Yeah, well, this will lead to a question for Dr. Hendricks, but it starts with somebody earlier asked Professor Riley about moving from her effectiveness focused presentation to efficacy trials. And, I was thinking, when that discussion was going on, that typical efficacy trial has a primary endpoint. I mean, most phase 3 studies have a selected and identified single primary endpoint. So that's probably not going to change based upon, even this discussion. But my question to Dr. Hendricks is, do you ever envision or work with a single primary endpoint and then a composite or global sort of secondary if the primary is hit? Because it seems like it would be a logical thing to do as opposed to going straight into the global as the overall endpoint in an efficacy trial.
Yeah, that's a really good question. And it's interesting because I think it depends a lot on the context. If you're in a small early phase proof of concept trial, doing it in that order could often kill the whole program because you're first using an outcome that's a little bit less sensitive and then an outcome that's more sensitive. And I do think if you're in phase 3, that could be a meaningful way to say, all right, we had an effect on CDR sum boxes. Is that an effect that's consistent across all the outcomes? And I think that's a good place to do it in that order. But if you're in proof of concept, we often advocate for putting the global first, doing the all-encompassing outcome first, because if you're really slowing down all aspects of disease, you'll see it much better on that combination score. And it's sort of the equivalent, using the hurdle analogy from earlier, putting the high hurdle first and then the low hurdle second. You know, you may never get to that second hurdle. But in proof of concept, what you're really trying to answer is, do we have an impact on the disease? And if you think you're impacting more than one aspect, trying to pick one ahead of time, put all your money on that one outcome is a lot to ask. And I think we should be allowing companies to use a combination endpoint first, and then use that for proof of concept, and then do a step down or hierarchical kind of approach to be able to test each component to say, okay, we have an overall impact, where are we seeing it the strongest? And then do something where you look at each individual outcome after that. So it really depends on the context of the study.
Can I jump in with one other question? And then I promise I'll stop. And this actually goes to Dr. Gibbons, because, you know, one of the things that Dr. Hendricks illustrated was that with highly correlated measures, there's less of an overall impact on the overall effect. And my question to you is about multidimensional IRT, and you're sort of the discoverer or inventor of bifactor model. In a multidimensional measurement matrix, does it matter how correlated the dimensions are, and do they have an effect on the performance of a multidimensional cat?
You're on mute.
It's still a great point. So one of the, in some sense, what you really want are that the partition for the global dimension in a bifactor model has very, very high correlation, but that the domains from which the items are selected are relatively independent of that primary dimension. So it's a little bit of both of those worlds. And one approach that you might think about, and I don't think it's really ever been thought about in the context of FDA, randomized clinical trials, is that instead of coming up with a unit-weighted composite measure of these potentially disparate kinds of measures, use the measurement science first and derive a composite measure using a bifactor model that would allow you to piece together these different domains into a global score. And now you have a single valued index that would obey the laws of a 0.05, critical value for your primary endpoint. And I think that same idea also, goes back to Dr. Riley, with, well, we explored all these measures and there's only 2 out of 3, even PROMIS with 3,000 measures has only like 5 of them. Well, why don't you just go out and take all of the different scales that exist and create a new item bank and then calibrate it using a multidimensional IRT model? You can even build a cat out of it. And now you've created this perfect world where if you administer that scale, you've got all 12 of them every single time. So again, I think it's important, we as statisticians, often don't pay much attention to measurement problems and the statistical science of measurement. We ignore it, but it's so important. And it makes the job of statisticians ultimately so much easier if the measurement science is done correctly.
I want to just add a comment there that the composite scores that we were referring to are exactly what you're talking about. We use a partial least squares regression model to align it with time, actual progression time, like each different time point of measurement, 0, 6 months, 12 months, 18 months, and then we optimize across those times. If you have a historical data set you can do that with, that really is the best way to get what is most progressive in this stage of disease out of everything we're measuring.
Mhm.
And
Luke, I
Laura,
see-
do you want to answer or ask your question that you put in chat?
No, well, I do.
Oh, do your first one and then I'll bring up the one that you put in chat. So it
Yeah,
doesn't
and
seem like you're
just
hogging.
like a minor qualifier in there that I think we want to be a little bit careful generalizing too much from survey measures to cognitive measures, because those can behave very, very differently because of things like sequence effects, which are true in survey measures as well, but to the extent that in cognitive measures, particularly for cognitive domains in which there's substantial learning across trials, or trials can interfere with each other, like memory trials where there's, interference between trials, we have to sort of test that these things work. So I just wanted to, just insert that comment in there. That's it.
And to the point of learning across trials, Luke, if I can just insert myself here right before you, because it's relevant to this, and it speaks to a comment that was placed in the chat during the cognition session. It was a great comment or question, and it said, can computerized adaptive testing, can CAT eliminate the unwanted practice effects while keeping the wanted practice effects? Because there were also discussions by Dr. Silverberg and others on the chat that said, sometimes practice effects could be useful. We don't want to necessarily throw out the baby with the bathwater or throw out the bathwater.
Yeah, I mean, I think that's a great point. What you want to eliminate is the redundancy. You want to eliminate that, in psychological measurement, the PHQ-9 or the PHQ-2, the most widely used mental health assessment. You're being asked those same questions over and over again. That produces all kinds of response bias. Similarly, one of the limitations on cognitive measurement, cognitive ability measurement, is this idea that you're going to be, given exactly the same task over and over again. The idea of measurement is that we want to do a great job of measuring the latent variable, and people will continue to learn about that latent variable through its manifestations, which are the individual items that you're using to assess it. But there's no reason that you should, there's a benefit of giving the same item over and over again. That's a little different than, really the ability to identify, here is a person who is learning. Laura's examples of, these different patterns and profiles and what we can learn from these high frequency measurements in terms of both the mean functions and the variability functions. So I think that there's really not the need to have the same thing over and over again to identify learning and different styles and cognitive abilities. And you can use CAT for that. Many of the items in the item bank are near redundancies of each other, and that's fine. But they can be used in exchangeable sessions, longitudinal sessions, so that you're not administering the same questions.
Mm-hmm. Yeah, just to add to that. Oh, sorry, I didn't. Go ahead, David. I'll jump in a minute. It's
so I was just going to say, all that said, you could, Robert, start with the same item, the same task every time, and then see over time if that task ultimately shows diff because people have learned that particular task as opposed to the newer ones that come in. I mean, so I think there could be a creative way to kind of have your cake and eat it too, where you're removing the practice effect for the most part, but having a planned evaluation of whether there's practice effect as determined by differential item function downstream could be designed that way.
I think that's a great point, and maybe that's a way of differentiating practice effects from learning. And you've got an internal control, and in many CATs we do that. There's certain items that you wouldn't want to take a chance that they wouldn't adaptively come up, particularly in, for example, a suicide scale. You need to have items about suicidality, and so there might be requirements that those items are fixed in the adaptive administration.
Last comment, but I think ultimately what is learning depends on what you're trying to measure, right? So if you're trying to measure how well someone remembers something, then learning previous items is in fact a thing you're measuring. But if you're not trying to measure memory, then memory from previous trials is now a nuisance practice effect, right? So I think there's a sort of domain specificity here too of like practice effects aggregate across many different things that are being learned or practiced. And if you care about any of them, then any practice effect goes. But if you care about specific ones, then you want to differentiate between them.
Yeah, I wanted to bring attention to that. I think I mean, we're talking about some specific aspect of repeated testing, particularly in cognitive outcomes, that is tremendously important. But there are lots of other variables that take place in repeated testing, right? That I think we haven't focused as much, that it might be particularly important to think about when we're thinking about populations with less familiarity with testing, or less even familiarity with the testing situation, and how that might impact retest effects, progression to the mean type of effects, and other sorts of effects that I think we need to just, I know that we all know about them, but that we need to consider as well as we're thinking, and not just get focused on the practice effect as if it's like the only thing that's happening in retest effects. There are also situational factors like stereotype threat that might come up in one situation and not the next one, depending on the environment that you're in. And this is not just random error. These are systematic changes, systematic effects that might impact people from certain backgrounds more than others, and depending on the testing situation. So just to bring it, not like a clear answer, but just something else to make sure that we're thinking about those as well when we're thinking about repeated testing.
Thank you. I'd like to switch topics if that's okay, and try to bring in voices that we haven't heard so far to the meeting. And so actually, Laura brought this up in chat, but for those who've worked with persons living with dementia or persons living with cognitive impairment and their care partners, we'd love to hear more about outcomes or measures that came up that folks consider problematic, stigmatizing, or marginalizing. That is, measures we should perhaps avoid or use with care or caution. In high frequency designs, for example, we have found people with mental health concerns sometimes find the focus on quote unquote the mean to be overly reductive and dismissive. And you have happy to elaborate. I don't know if you want to follow up on that, Laura.
Maybe just briefly. So I use that case as perhaps a non-obvious one. There might be really obvious ones that have come up in talking to folks with dementia and their care partners. But in this case, we often talk about like your average depression level, your average anxiety level over the last 2 weeks or something, right? Like what a person cares about is their worst day. That day when they made really bad life decisions and maybe jeopardized their most important relationships. The mean doesn't reflect that. The extremes reflect that. And so in talking to patients, because we do a lot of return of research results to patients, we found that that's something where when we focus on the mean, to them, that's a way of invalidating the variability of their experience. So I'm just curious if in the dementia context, things have come up as outcomes where if we don't communicate them right, or maybe they're just not even good to use. So the opposite of the best outcomes, but what are the worst outcomes that have come out in that kind of qualitative work?
So I guess I'll comment, but it's a little bit different than what I was talking about. But I think this does come to the point of, when we're talking about groups of subjects and we are talking about means, there's an entire distribution around that. One of the places we've seen that to be really important is when we talk about fast progressors in the Alzheimer's space. And originally, when I heard about the fast progressors, I thought, well, it's not going to impact things that much. But then since then, I've seen a lot of research that shows it can impact your groups quite substantially. A few extra fast progressors, they have outlier effects. They're unduly influential, and it can make a really big difference. And I think when we're talking about groups of patients, in addition to showing mean comparisons, it would be nice on a per person basis also to show the fastest and slowest progressors, and even show percentiles within those different progression rates. And I think then one step beyond that is what you were talking about, which is within an individual showing what their best and worst days end up being. And I think some of these digital biomarkers that we're talking about will allow us to do some of those kinds of things, because we're collecting so many data points over so much time, we're collapsing them to overall scores. And some of those scores are sort of means and medians and, you know, reducing to some representation of the middle. But I think there should be others that either represent the variability or the best day or the worst day, and then bring those into some of these models as well. You know, how much are we changing someone's best day? How much are we changing their worst day? Are we, you know, truncating the top end of this distribution, or are we just moving the whole distribution together? I think those are all things we can do. And I think the digital biomarker space will give us a good way to do it within person, within day. And with percentiles, we can look at decline rates per person within studies or within observation periods and use those percentiles as comparisons. I think that could be really helpful.
I'll offer something, and I don't know that I'm gonna be specifically answering the question about worst measures. I do think that we're sort of maybe walking around a challenge, which is a scientific communication challenge around how we can explain the various assessment measures that somebody could have returned to them in a study. And I have this slogan that's really unpopular with many people. That's people are not their cognition. You know, someone's experience with their trajectory. I think when in the clinical arena, when we're communicating and talking about prognosis, this is often very difficult for people to understand because, you know, what is expected and where am I relative to where are other people, and recognizing the heterogeneity that we know is present. I don't think we've mastered useful scientific communication practices. So I think a part of this is also about how do we communicate the relative utility of these different data points to individuals. And I don't think we've investigated that, but I think that's like an empiric question. And I think we need science communication experts working with us in the ADRD space. And that hasn't really happened yet. But same thing with, I think this has really come to light with some of the immunotherapy treatments, and like, how do we communicate these findings to people? And there's a real ethical issue embedded within that as well, the fact that we haven't figured that out. But we're ready to, you know, to start bringing people to these clinics and talking to them about that, but we don't understand whether or not we're communicating, you know, these different scores in ways that make sense to people or how people interpret them. So I just want to highlight that as like not answering your direct question, but maybe that's a part of the challenge that we encounter with things that can be problematic, is our own clarity in the scientific community, but also communicating that clearly to folks.
Yeah, I think that's an excellent point and a core issue, while also acknowledging that it might not just be a communication failure if someone finds a discrepancy between what they're being told and what they experience. It could be that truly there's a gap as well.
Yeah, I echo that. I think it's an extremely important point. And I think as we think about those communication strategies and how we are sharing our science with, you know, with the rest of the world, and who we care that understands our science and that knows, you know, we're speaking the same languages, we should also consider you know, how this happens across cultures and across languages. Like a very simple example is in Spanish, I cannot use the word dementia for anything ever. And I think lots of people know that. The translation of that term is just triggers something that is very associated with something that's not what we are talking about here. So just being mindful of that as we create this language to how to communicate. I think it's important to think again, what's important for different people, different cultures and different languages would go a long way for these international efforts as well.
Great. And if other speakers or moderators from later sessions would like to come on and ask questions of today's speakers, feel free to jump in. I want to reinforce a point made in chat by Cheryl Kuhn. So Laura's point about the average over time or the worst day being more reflective of what's meaningful to individuals is important. This is why qualitative research is critical to understand how we need to be framing questions and the scores that we compute from them. It's not just a statistical psychometric question. Very good. And NIH folks too, if you have any questions or any points that were shared in chat that you felt could use additional focus or consideration, feel free to bring those up.
Luke, I have two comments. Really, I'm just underscoring other people's points already. I know Ian earlier in chat mentioned something about disease-specific variation. I think we even brought it up earlier, but I just wanted to mention that again, just as a reminder that that may play a significant role in the way that we ascertain people's experience. So that's just a comment. And then a broader question to sort of elevate my colleague Melissa Riddle's comment from earlier about the complexities of interventions and the lives that people live in, that maybe a sole outcome may not be viable in terms of our scientific inquiry. We might be looking at something much more complicated than whether you're taking a specific drug or you're so the complexity of inquiry, I think, is important when we're thinking about what matters to those who are experiencing clinical trials and ADRD specifically, or sort of more broadly. So I just wanted to highlight those two comments that were not mine, but I wanted to make sure that they were raised again. And I see that Dr. Peterson has his hand up.
Yeah, you want to go ahead, Ron?
Sure. Thanks, Luke. I appreciate the conversation. Very complex and daunting in many respects. And I want to take off what Lena just said. Not only is there complexity in these issues with regard to stage of disease, from preclinical, say, mild cognitive impairment, mild, moderate, severe stages of dementia, but then you cross-index that with the underlying disease process. You're talking about AD, FTD, DLB, VCID, and you've got more complex issues. So I appreciate the difficulty here. So I guess my question would be, does the panel think that there might be any cross-cutting kinds of instruments that really could bear upon these different levels of complexity of an individual disease and then the variable disease processes themselves? Would IRT do that? Could there be an assessment approach that could really get at some fundamental underlying features across these different entities?
To the extent that the item bank is measuring different domains that are reflective of those different diseases, and that the items within those domains have wide variability in terms of their difficulty, then calibrating using a multidimensional IRT model and then using CAT to adaptively select the best items for a person conditional on their severity, which is learned through the adaptive administration process, would be ideal for that kind of setup. It's in our initial studies of the prototype CAT, we found that these measures were sensitive to 18-year-olds who were, on the internet sample, to the 17 cases of mild cognitive impairment from the radix sample. But they were getting very different types of adaptively administered items that were, rapidly selected on the basis of their ability to do the initial item.
So conceivably, it's possible. And that would be encouraging because this is such a complex area, but I appreciate that.
Yeah, my long-winded answer was yes.
Thank you.
Andrea?
Yeah, I think that was a great question. It just made me think, I know something that we're wanting to do, I think, is continue to think about research opportunities and gaps as through this discussion. And I see you nodding. So this is an appropriate time for us to still be doing that. So one thing that's come to mind with, how we want to think about other measurement opportunities and thinking about David's talk, I don't actually think that we have very well developed methods for some of these steps of like cognitive debriefing and some of these validation steps with individuals who are experiencing cognitive changes and at different stages. So and also just recognize we don't really have like sufficient cross-cultural understandings of priorities. So in order to develop that, we also seem to have this gap of, the right methods and strategies to do what are sometimes cognitively challenging tasks, where you might be holding all items in your head at once and kind of rank ordering them. So identifying that maybe we have another opportunity there, which is methodological in nature to achieve next steps.
Thanks. Yeah. So, Andrew, you're doing good modeling. So we do want you to, bring up questions that you have for each other, engage in conversation together, but also identify gaps and opportunities like Andrea just did. So the end of the day, during the general discussion is a great time to do that. And again, we also recognize that everybody's not going to be comfortable sharing in this large space, either verbally or in chat. So we have points of contact, myself and Nicole. Feel free to email us. I know many of you have already been doing that, which we appreciate. So whatever way is best for you to, engage in the topics that we're discussing at the meeting, please do so. Okay, I'm going to turn it to Rosie, who has another identified gap and opportunity. Rosie?
Well, it was just trying to reiterate Andrea's point about, and the way that I conceptualized it was better equipoise when we have these data, particularly during early stages of disease, particularly in the clinical realm where we have someone that they may consider novel emerging treatments, to really try to use the data before us to present things using equipoise, present results using equipoise. So I think it's a challenge that was identified by Andrea and others. And I just tried to reiterate it in writing, but we'll organize our thoughts more around that, perhaps, on Thursday or an ongoing conversation, because I think we should do that right along in terms of the patient-centered, the patient delivery end. But there is also a note on the chat from a person that's living with this experience of having Alzheimer's disease, or it says, I was not accepted into an Alzheimer's research study because my score was 1 point too high. 2 prior research screenings in the past 6 months with identical questions and tests. My cognition and memory has gotten worse, but it was not reflected in the testing. I knew the questions that I'd be asked: date, time, location of the study, copy the pyramid, these sorts of things. And thank you so much for sharing that. That's very insightful information, and something that we absolutely worry about is whether or not we're missing people because of our methods, whether we're failing people because we're missing people that could benefit from treatment because of some of the issues that were described today, such as practice effects, for example. I don't know if anyone would like to comment further on that.
I'll comment further on that.
Thank you.
I'm Cynthia Hewling-Hummel, and I've been in the ADNI study since 2010. But the ADNI study, ADNI 4, has been paused in my area, and I was looking for an opportunity to engage in interventional research rather than observational. And it was discouraging. I mean, I know how much my memory has declined over the years and how much trouble I have on a day-to-day basis. And on the one hand, it's wonderful to be told, I'm sorry, we can't accept you into this study because your score is too high. On the other hand, I felt it wasn't reflective because I've had the same questions since I've started the whole research study process. There's very little difference. And, I'm just sharing that as my observation and my experience.
I'm curious, Cynthia, thank you for sharing that. Were you ever given your results from your testing on previous time points? Like when you did screening, these screening tests for the other research studies, were you ever given your scores? Like I'm thinking, for example, from the first time in an ideal world, and obviously we aren't in an ideal world, but you would always get that data back and you could have taken the test results from that first time point to the study team that you most recently engaged with, but maybe that wasn't something you had.
It wasn't something that I remember having.
Yeah, okay. Well, quick plug to the entire group in that case for how important it is to give back research data to individual patients, because situations like this, better research data for the research, you would have had your scores and potentially had a more valid set of scores for this particular opportunity.
Yes, indeed.
And those that want it. So really respecting as research volunteers, those that want to receive feedback. I always educate my patients. I say, you know, there are three kinds of patients: the ones who want to know everything, the ones who don't want to know anything, and the ones who want to know just enough, right? Tell my husband the rest, or tell my wife the rest. And I really think it's important to honor what the patient wants to know, how much they want to know, and deliver it in a manner that is that they prefer, with the people around them that they prefer. And so I think it's really important to educate, especially now when we have at our fingertips so many novel and useful diagnostic and prognostic measures.
And please remember those of us who live alone. Many of us do.
Yeah, I just wanted to, so I could, Cynthia, thank you so much for sharing your experience and highlight also what Rossi just said. I think it's a tremendously important point as we look forward into this new scale of methods that might be widely available. I think it's tremendously important what Laura's bringing up of sharing results. I think it's also tremendously important that we're mindful of who might or might not want the results, so that we consider this in the implementation of these approaches. I know I try to be very mindful of that in this development of these new digital tools. I think that some people might really appreciate it, might want it, and some might not. It's a little, so I just wanted to highlight that as an important thing as we move forward, that I think this individualized approach where we're considering people's perspectives is tremendously important. And the coordination among us researchers, I think it's another very important point that maybe we can make some progress on, so that situations like the one Cynthia has experienced don't need to experience others. I've also had the experience many times with some of the people that I've worked with, it's the opposite, that people don't make it into studies because their score is too low, without consideration of educational background factors. So this use of cutoff scores that don't really consider at all prior experience of people, whichever it is, right? Prior experience with the testing, prior experience, educational level, what, you were never taught to do, and not considering those elements in who gets into these trials. I think it's important that we get past that. I think we've known this for a long, long time, and it's not always implemented in our research.
I hope you'll all come on Thursday. I'm on a panel discussion with several other people who have the lived experience, and we'll be sharing what's clinically relevant for us and what our wishes are as research moves forward. So please do plan to join us on Thursday.
So Cynthia, you beat me to my plug. I was going to plug the lived experience expert panel on Thursday, so you've already done that. We'll also have a speaker tomorrow as well, and so you'll hear more. So we would really do appreciate all the folks with lived experience that are participating here. In the interest of time, we're almost at close for day one. This has been an incredibly rich conversation. I want to emphasize a couple points again that have been expressed as general points, and then the challenge to this group. I think one thing is the fact that we have lots of heterogeneity, both in the disease, but also in the lived experience of being human with these diseases. And the challenge is, I think, how do we best define our measures and measurement approaches to capture those experiences for individuals? How do we return information to individuals to center them in this process? And I think, that's the hard challenge that we have as a group that we'll continue discussing over the next couple days. I want to thank everybody again, speakers and moderators, for today. And tomorrow we'll start the day with Dr. Peterson, who had a question that closed today, talking about what matters in the community context. And then we'll have our biomarkers session that follows that. And then the payers, regulators, and health economics session will follow a similar format where we'll have speakers giving brief talks after Dr. Peterson's 30-minute keynote. And then we'll have general discussion to close. I encourage everyone to please show up tomorrow and Thursday, continue to participate. On Thursday, again, we'll have an opportunity for deep engagement with each other in the breakouts, and then a final general discussion session. So thank you, everyone. And we'll end a couple minutes early in the interest of giving everyone their very valuable time back. See you tomorrow.